जितना बड़ा साइज है पेशेंट का उतना ज़्यादा फोर्सफुली आपके वेंट्रिकल को कॉन्ट्रैक्ट करके ब्लड पहुंचाना पड़ेगा। जितना कम वेट होगा उतना ही बर्डन कम होगा। सो बोथ वेज इट इज़ बेनिफिशियल टू अ पेशेंट विद हार्ट फेलियर। एजेक्शन फ्रैक्शन नॉर्मल 60 है, 60 के बहुत करीब ही है तो वी विल कॉल इट एज हार्ट फेलियर विद रिड्यूस्ड प्रिजर्व्ड एजेक्शन फ्रैक्शन, और 40 से कम है तो वी विल कॉल इट एज हार्ट फेलियर विद रिड्यूस्ड एजेक्शन फ्रैक्शन। FMG, नीट PG, INICT कोई भी एग्जाम उठा लो, एक क्वेश्चन रिलेटेड टू SGLT2 इनहिबिटर्स हमेशा आया। स्टडीज आफ्टर स्टडीज हैव शोन दैट वो हार्ट फेलियर के मॉर्टेलिटी को रिड्यूस करता है। Hi guys, welcome everyone. So this SR booster one shots. So we're starting with medicine today, and my other faculty members, other colleagues will follow from tomorrow. Okay. So what are we going to do? We will take up some MCQs and try to understand few more points about the topics on which these MCQs are framed, so that we not only know the question but also the few points about those topics. I do not want to waste most of your time because the exam is just around the corner, so we'll directly get into the question. So here is our first question. So in this question, we have a 65-year-old who presented with dyspnea on exertion, orthopnea, and bilateral lower extremity edema. Dyspnea on exertion, orthopnea, bilateral lower extremity edema. On examination, there are crackles at the lung basis and an elevated jugular venous pressure. Echocardiography reveals an ejection fraction of 35% with global hypokinesia. Which of the following medication is indicated for symptomatic relief as well as mortality reduction in this patient? So few points to address here. What is your diagnosis in this question? What do you think? See, from the symptoms, we understand that we are talking about a cardiac patient. This is a serious question. What do we have? What are the diseases that we have in cardiovascular system? We have diseases of the pericardium. We call it as acute or chronic pericarditis. Then we have disease of the myocardium. We call them as myocarditis, cardiomyopathies. Then we diseases of the endocardium. We call it as endocarditis, infectious, non-infectious. We have valvular heart diseases affecting the valve, right? Then we have diseases affecting the coronaries. We call them as coronary artery disease or ischemic heart disease. And when any of these alter the functions of the heart, we end up developing impairment of cardiac function. We call it as heart failure. So among all this, what is the diagnosis that you think of? So this is probably heart failure, right? Heart failure. Now, what symptoms make me think of heart failure here? Number one, patient has exertional dyspnea, orthopnea, PND. All that indicates that there is elevated left atrial pressure. Patient also has bilateral pericardial edema. That indicates either there is elevated right atrial pressure or patient also has activation of renin-angiotensin-aldosterone system. That has resulted in all these symptoms. That makes me think of heart failure. Now, when it comes to heart failure, we classify heart failure into three broad groups. That is the current classification. That is heart failure with reduced ejection fraction, preserved ejection fraction, and the heart failure with mid-range ejection fraction. Now, looking at the ejection fraction in this case, what do you think should be the diagnosis? I will give you a few points about heart failure, but I want you to participate and give me an idea what you're thinking about. Right. So this is congestive cardiac failure. KM initial, yes, this will be available as a recording. You can watch later also. So this is heart failure with reduced ejection fraction. So when do we call it as heart failure with reduced ejection fraction? What should be the ejection fraction to say that it is reduced? Right, it is less than 40%. Okay. Now, what is the question that examiner is asking us? Which of the following medication is indicated for? One, it should improve the symptom, but at the same time, it should reduce the mortality in this patient. So what should be the answer? What should be the answer here? Is it digoxin, mildrenone, carvedilol, or nifedipine? So we'll spend little time understanding heart failure because that is an essentially important topic. Okay. So what is heart failure? Heart failure basically refers to either impaired ejection of the blood from the ventricles or impaired filling of the ventricle. See, normally what happens? We have two ventricles, right and the left ventricles. We fill the blood into the ventricles from their respective atria during diastole. Ventricle should be able to fill well, right? So that is one part. Second, once we fill them, whatever blood that we have filled into the ventricle, we should be able to eject them efficiently into their respective arteries, from right ventricle to pulmonary artery and left ventricle to aorta. If any of that gets impaired, we call it as heart failure. Either we are not able to fill it, that is heart failure. We are able to fill it well, but still not able to eject well, that is also heart failure. Okay. So from the topic, what we need to understand? First, you need to know the diagnostic criteria for heart failure. Second, you need to know the classification of heart failure based on the ejection fraction. You should have a fair idea about the pathophysiology and what drugs reduce mortality, what drugs improve symptoms, and what drugs actually increase the mortality. That is the area of contention for MCQs. So now, what is the criteria for diagnosis of heart failure? In any patient who presented with signs and symptoms of heart failure, we have to prove that these symptoms are indeed because of heart failure. How do we prove? Whenever heart fails, the pressures inside the right or the left atrium starts increasing, and that leads to stretching of the atrial chambers. And when heart's chambers get stretched, they release a chemical substance. What is that? It is the natriuretic peptides. So we check for that. So either elevated BNP or pro BNP levels. This is the diagnostic criteria for heart failure. You should have signs and symptoms of heart failure. The right heart failure leads to rise in JVP, pedal edema. Then the congestive hepatomegaly. Left heart failure leads to the congestion of the lungs, resulting in orthopnea, BND. Right? If these symptoms are there, it is signs and symptoms of heart failure. Along with that, elevated BNP or pro-BNP makes it a case of heart failure. Now, once I have a case of heart failure, next thing is the classification. How do we classify heart failure? The classification of heart failure is based on ejection fraction. For that, we need to understand what ejection fraction means. Right? It is based on ejection fraction. Earlier, there were other classifications like we used to call it as systolic heart failure, diastolic heart failure. We used to call it as right heart failure, left heart failure. But currently, most commonly practiced classification system is based on ejection fraction. Okay. Is there anyone who can give me the formula for ejection fraction? Ejection fraction refers to expression of percentage. That is, ejection fraction is equal to stroke volume divided by the end diastolic volume, and to express it in percentage we are multiplying it with 100. That is the formula for ejection fraction. Now, what is stroke volume? It is the amount of blood ejected from the ventricle during one contraction. When does it contract? During systole. What is EDV? End diastolic volume. So let us understand this a little bit. This is my left ventricle. This is my left atrium. Okay. From the left atrium, I fill the blood into the left ventricle during diastole. Right. Now, I have completed the diastole. So there is some amount of blood in the left ventricle. This blood that is there at the end of the diastole in the left ventricle is what we call as end diastolic volume. Now this ventricle will contract in the next systole and eject the blood into the aorta. From the left ventricle, we eject the blood into the aorta during contraction. Now obviously we will not be able to eject all this blood. We eject some amount of blood. Right? So whatever amount of blood that we eject out in one contraction, we call it as stroke volume. So a ratio of end diastolic volume by amount of blood ejected as stroke volume. That ratio gives us the ejection fraction. To express it in percentage, we multiply it with 100. Okay. Now what is the normal ejection fraction? The normal ejection fraction is in the range of 60 to 70%. 60 to 70%. On the basis of ejection fraction, they will ask you two questions. When do you call it as heart failure with reduced ejection fraction? And in what condition you can have increased ejection fraction, right? More than 70%. So please remember, EF more than 70% can be seen in patients with, see, in what condition I will be able to contract the ventricle strongly and eject more than usual amount of blood? When I have highly muscular ventricle, right? So where do we see that? In patients with hypertrophic cardiomyopathy. In patients with hypertrophic cardiomyopathy, you can have ejection fraction greater than 70%. Okay. Now, how do we classify heart failure based on the ejection fraction? If the ejection fraction is less than 40%, less than 40%, we call it as heart failure with reduced ejection fraction. And if it is EF less than 40%, we call it as heart failure with reduced ejection fraction, or it is usually abbreviated as HFrEF. R here stands for reduced ejection fraction. That is heart failure with reduced ejection fraction. And if EF is more than 50%, more than or equal to 50%, we call it as heart failure with preserved ejection fraction. Normal 60 है, 60 के बहुत करीब ही है, तो we will call it as heart failure with reduced preserved ejection fraction. और 40 से कम है तो we will call it as heart failure with reduced ejection fraction. In between 40 to 50% ejection fraction है तो we will call it as heart failure with mid range ejection fraction. Heart failure with mid range ejection fraction, when your EF is more than 40% but less than 50%. EF is more than 40% but less than 50%, we call it as heart failure with mid-range ejection fraction. Normally, heart failure with reduced ejection fraction में problem क्या होता है? These patients ventricles are not able to contract well. इसीलिए the stroke volume has decreased, and that is why the ejection fraction is decreased. Clear? So it indicates systolic heart failure. And heart failure with the preserved ejection fraction is condition where we are not able to fill the ventricle well, because ventricle is hypertrophic, uski cavity choti ho gayi hai, so we are not able to fill well. So in these patients there is reduction in the end diastolic volume. End diastolic volume reduction होने की वजह से stroke volume भी reduce हुआ है, but when you look at the ratio, not much of reduction. That is why it comes out as EF very close to normal. Such condition primarily indicates that impairment कहाँ पे है? Filling of the ventricles. So we will call it as diastolic heart failure. Diastolic heart failure. तो जो भी patient इस question में हमने देखा, this patient is suffering from heart failure with reduced ejection fraction because this patient's ejection fraction is less than 40%. Okay. So what else they will ask you on heart failure? They will ask you about the causes for heart failure. Now important MCQ points are: what is the most common risk factor for heart failure? Okay. What is the most common cause for heart failure with reduced ejection fraction? What is the most common cause for heart failure with preserved ejection fraction? 3 MCQ points. Right. So the most common risk factor for heart failure is hypertension. हाइपरटेंशन क्यों रिस्क फैक्टर है? हाइपरटेंशन की वजह से लेफ्ट वेंट्रिकुलर हाइपरट्रोफी होती है. सो व्हेन लेफ्ट वेंट्रिकल डेवलप्स हाइपरट्रोफी, वी डेवलप कॉन्सेंट्रिक हाइपरट्रोफी. तो अंदर की तरफ और मसल ऐड होता जाएगा, तो वेंट्रिकल की कैविटी छोटी हो जाती है. तो कैविटी छोटी है तो हम कम ब्लड इसमें फिल कर पाएंगे, तो एंड डायस्टोलिक वॉल्यूम रेड्यूस. राइट, क्लियर? ओके. देन मोस्ट कॉमन कॉज फॉर हार्ट फेल्यूर विथ reduced ejection fraction is ischemic heart disease. ischemic heart disease क्यों मोस्ट कॉमन कॉज है? बिकॉज अगर मायोकार्डियम के किसी हिस्से को ब्लड सप्लाई नहीं मिल रहा है, इफ इट इज नॉट गेटिंग सफिशिएंट ब्लड सप्लाई, विल इट बी एबल टू कॉन्ट्रैक्ट वेल? नो. इफ इट डज नॉट कॉन्ट्रैक्ट वेल, देन ऑब्वियसली जो एजेक्शन होगा वो कम हो. राइट. सो स्ट्रोक वॉल्यूम विल बी लेस, एजेक्शन फ्रैक्शन विल बी लेस. एंड द मोस्ट कॉमन कॉज for heart failure with preserved ejection fraction is going to be hypertension. Okay, these are the basic points we should understand from the etiology. Now in terms of how we manage heart failure, I will take just 2 minutes to brief you about what is the problem that happens in a patient with heart failure. So we need to have a quick idea about the pathophysiology of heart failure. अब heart failure में क्या होता है? When heart fails, it leads to two major outcomes. First क्या होगा? There is reduction in cardiac output. Cardiac output क्यों कम हो रहा है? बिकॉज या तो आपके वेंट्रिकल ठीक से कॉन्ट्रैक्ट नहीं कर पा रहा है, तो आप कितने भी ब्लड वेंट्रिकल में भरो वो एजेक्ट कम ही कर रहा है. स्ट्रोक वॉल्यूम कम हुआ है तो कार्डियक आउटपुट कम होगा. सो प्लीज रिमेंबर फ्रॉम फिजियोलॉजी देयर इज अ डेफिनेशन फॉर कार्डियक आउटपुट. कार्डियक आउटपुट इज इक्वल टू स्ट्रोक वॉल्यूम इनटू हार्ट रेट. तो जब स्ट्रोक वॉल्यूम कम होता है the cardiac output will come down, right? Similarly, even if you look at heart failure with preserved ejection fraction, यहाँ पे क्या हो रहा है, ejection fraction नॉर्मल है, ओके, लेकिन एंड डायस्टोलिक वॉल्यूम डिक्रीज हुआ है, एंड डायस्टोलिक वॉल्यूम डिक्रीज हुआ है और एजेक्शन फ्रैक्शन को नॉर्मल रखना है, तो रिजल्टेंट स्ट्रोक वॉल्यूम विल बी डिक्रीज। सिंपल से समझो, वेंट्रिकल एक बैंक की तरह, राइट? अगर लोग बैंक में डिपॉजिट करेंगे तो तभी बैंक लोन दे सकता है। तो अगर लोग बैंक में पैसे कम डालेंगे तो बैंक को लोन देने की कैपेबिलिटी भी कम ही रहेगी। सो अगर कम ब्लड वेंट्रिकल में पहुंचेगा, वेंट्रिकल खुद से तो ब्लड नहीं बनाता है, राइट? जैसे कि आरबीआई सिर्फ आरबीआई प्रिंट कर सकता है, आपकी एचडीएफसी, एक्सिस बैंक, दे कैन नॉट प्रिंट मनी। सो इफ पीपल आर पुटिंग मनी इनटू एचडीएफसी, देन ओनली दे कैन गिव द लोन। अगर लोग एचडीएफसी में पैसे नहीं डाल रहे हैं तो एचडीएफसी भी लोन नहीं दे सकती। सो इफ आई डोंट फिल द वेंट्रिकल सफिशिएंटली, I cannot eject sufficiently, simple है, right? So ultimately heart failure preserved ejection fraction वाला हो या reduced, cardiac output तो कम होती है। And when cardiac output decreases, what will happen to our blood pressure? Please remember, our systolic BP is directly proportionate to stroke volume, or I can say indirectly it is proportionate to cardiac output. Cardiac output कम होती है तो systolic BP भी कम होती है, so there will be drop in BP, and when BP drops, obviously body will try to make corrective steps, right? So this will activate two important changes in the body. See, BP come hote hue we can't keep quiet, otherwise our kidneys will start failing first. After that, the liver, brain and lungs will also start losing the functions because they need constant blood supply. To maintain the BP, what I can do? One, I can activate renin, angiotensin, aldosterone system, right? Second thing I can activate is the sympathetic nervous system. Sympathetic nervous system. So once I activate renin, angiotensin, aldosterone system, इसमें दो कंपोनेंट्स है, एक है एंजियोटेंसिन 2 AT2 और दूसरा क्या है, एल्डोस्टेरॉन। So what angiotensin 2 will do? The angiotensin 2 will cause vasoconstriction. Vasoconstriction. Okay. अगर मैं sympathetic nervous system को activate करूंगा तो this will cause, sympathetic nervous system will also cause vasoconstriction. तो ये जो vasoconstriction है, this can improve the blood pressure. This can reset the blood pressure to normalcy. This has the ability to normalize BP. तो कैसे कर रहा है? Again, we get back to the physiology. Physiology में हमने एक और formula पढ़ी है. The formula is Boyle's law. What Boyle's law says? Boyle's law कहती है that our pressure in any closed system is inversely proportionate to volume. Is inversely proportionate to its volume. तो arterial system मतलब collection of pipes, right? They are closed system. तो अगर इसको कंस्ट्रिक्ट करके वॉल्यूम कम करेंगे तो इसका अंदर का प्रेशर क्या होगा? जैसे ही वॉल्यूम डिक्रीज होगा तो प्रेशर इंक्रीज होगा, बिकॉज दैट इनवर्सली प्रोपोर्शनल। सो बाय कंस्ट्रिक्टिंग द ब्लड वेसल्स, वॉल्यूम कम कर रहे हैं तो प्रेशर ज्यादा कर रहे हैं, दैट्स हाउ बीपी इज गेटिंग नॉर्मलाइज्ड। बट एम आई गेटिंग द हायर कार्डियक आउटपुट? नो, सिर्फ ब्लड प्रेशर नॉर्मलाइज हो रहा है, कार्डियक आउटपुट तो फिर भी कम ही है, राइट? फिर दूसरा क्या हो रहा है? अल्डोस्टेरॉन। व्हाट अल्डोस्टेरॉन विल डू? Aldosterone will increase sodium and water reabsorption at kidney. तो किडनी में सोडियम एंड वाटर रीअब्सॉर्प्शन बढ़ने लगेगा, and that will increase the circulating blood volume, or what you call as the plasma volume. So this will increase plasma volume, increase in the plasma volume. और जो वेसोकंस्ट्रिक्शन हो रहा है उसके वजह से द कंस्ट्रिक्टेड ब्लड वेसल के खिलाफ अब हमारे वेंट्रिकल को ब्लड पुश करना पड़ेगा, तो इट्स वर्क इज इंक्रीजिंग. सो दिस वर्क इज व्हाट वी कॉल एज द आफ्टर लोड. एंड अब वॉल्यूम बढ़ गया तो उस एक्स्ट्रा वॉल्यूम जो वेंट्रिकल को मिल रहा है उसको वो पंप करना पड़ेगा. दिस वॉल्यूम इज व्हाट वी कॉल एज द प्री लोड. तो प्री लोड इंक्रीज हो रहा है वेन एवर वी हैव एक्टिवेशन ऑफ अल्डोस्टेरॉन. अब ये जो इंक्रीज प्लाज्मा वॉल्यूम है, दैट कैन हेल्प मी टू नॉर्मलाइज द ब्लड प्रेशर. ये मेरे बीपी को नॉर्मलाइज कर सकता है. ओके, बट to some extent this expanded plasma volume may be able to increase the cardiac output, but not greatly. अब यहाँ पे क्या हुआ है? This adaptive change has not done much for improvement of cardiac output, लेकिन हार्ट के ऊपर preload और afterload दोनों बढ़ा दिया है, and this is going to be harmful for heart. क्योंकि काम जितना बढ़ेगा, जो हार्ट फेल हो रहा है काम और बढ़ा दो तो और फेल होगा. ओके. On the other hand, we also activate one more system which is called as the natriuretic peptide system. क्योंकि there is stretching of chambers of the heart, stretching of cardiac chambers, and these stretched chambers will send the signal कि हाँ भाई मेरा तो मतलब मेरा शरीर स्ट्रेच हो रहा है. मतलब क्या, इनडायरेक्टली वेंट्रिकल्स या एट्रिया समझेगी कि जो वॉल्यूम ऑफ ब्लड है वो ज्यादा हो गया, इसलिए वी आर बीइंग स्ट्रेच. तो वो सिग्नल भेजेंगे किडनी को कि हाँ वॉल्यूम बहुत हो गया, हम हैंडल नहीं कर पा रहे हैं, आप इनको कम करो. What is that signal called as? We call them as natriuretic peptides like ANP, BNP. Right? We will release ANP and BNP. We call them as natriuretic peptides. इसके नाम में ही है, राइट, नेट्रीयूरेटिक पेप्टाइड. नाम क्या है? नेट्री मतलब सोडियम, यूरेसिस मींस मेक यू लूज. एंड प्लीज रिमेंबर सोडियम इज एन ऑस्मोटिकली एक्टिव सब्सटेंस, तो अकेले नहीं जाएगा, साथ में पानी लेके जाएगा. सो दिस विल इंक्रीज sodium and water excretion, sodium and water excretion at the level of kidney. तो ये exactly opposite काम कर रहा है of what your aldosterone does, right? Aldosterone increases sodium and water reabsorption, ये sodium and water excretion को increase कर रहा है. And by doing this, what is it causing? It is causing reduction in preload, reduction in preload. ये beneficial है हार्ट के लिए, क्योंकि आपके फेल होते हुए हार्ट को कम बर्डन देना चाहिए. ज्यादा बर्डन तो और ज्यादा तेजी से फेल होगा, इट विल टेक यू टूवर्ड डेथ और मोर्टेलिटी. तो व्हेन इट कम्स टू ट्रीटमेंट, राइट, हमको क्या क्या करना पड़ेगा एक हार्ट फेलियर पेशेंट को? अंडरलाइन कॉज को ट्रीट करना पड़ेगा. अगर हाइपरटेंशन है या इस्केमिक हार्ट डिसीज है तो अकॉर्डिंग टू दैट वी हैव टू ट्रीट. बट हार्ट फेलियर को सुधारने के लिए क्या करना चाहिए? ये जो है रास और सिंपैथेटिक नर्वस सिस्टम, इसको स्टिमुलेट करना चाहिए, ब्लॉक करना चाहिए. आई थिंक आई टोल्ड यू इट इज हार्मफुल, राइट? सो वी शुड ब्लॉक इट. So how can I block sympathetic nervous system? Sympathetic nervous system में क्या है? We have mainly the adrenaline, noradrenaline, dopamine, mainly adrenaline. Okay. अब इनके receptors को मैं कैसे block कर सकता हूँ? Right? I have to block the beta receptors. So for that we have beta blockers. So beta blockers will be useful for a patient with heart failure. दूसरा क्या है? एंजियोटेंसिन 2. इसको कैसे ब्लॉक कर सकता हूँ? या एंजियोटेंसिन 2 बनने से रोक सकता हूँ बाय इनहिबिटिंग द एसीई, या अगर बनने के बाद रोकना चाहता हूँ तो इसके रिसेप्टर्स को ब्लॉक कर सकता हूँ विद द हेल्प ऑफ एआरबीस. अब अल्डोस्टेरोन को कैसे ब्लॉक कर सकता हूँ? विद द हेल्प ऑफ ड्रग्स लाइक स्पाइरोनोलैक्टोन और एप्लिरिनोन और स्पाइरोनोल. तो ये सब हेल्पफुल होंगे क्योंकि दे आर गोइंग टू टैकल द हार्मफुल चेंजेस दैट आर हैपनिंग इन अ पेशेंट विद हार्ट फेलियर. और क्या कर सकता हूँ? ये जो एएनपी बीएनपी है इनको स्टिमुलेट करना चाहिए या इनके एक्शन को इम्प्रूव करना चाहिए, ताकि जो प्रीलोड रिडक्शन का बेनिफिट मिल रहा है वी कैन स्क्वीज इन मैक्स. अब ये कैसे कर सकते हैं? जो एएनपी बीएनपी बन जाते हैं, once they are synthesized, right, they get deactivated by an enzyme called as neprilysin. Neprilysin converts them into inactive peptides. Inactive peptides. तो मैं इनको ब्लॉक कर सकता हूँ. नेप्रिलाइसिन इनहिबिट करने की वजह से आई विल बी एबल टू get the action of ANP BNP prolonged, right? Example for that is, you might have come across many examples, but the one that is readily available in Indian market is Santhosh. Clear? So that is how we manage a patient with heart failure. So when it comes to its management, what all medications we will give to a patient with heart failure? Number one, we will give beta blockers. But I think first drug I should actually mention is AC inhibitor. That is what we generally start with. अगर AC inhibitors नहीं देना चाहते हो या patient has cough or other issues, you can give ARBs. क्यों दे रहे हैं? Because we definitely want to block the action of angiotensin 2. वो vasoconstriction करके after load बढ़ा के हार्ट को और फेल कर रहा है. Then I want to give beta blockers. Beta blockers का दो एडवांटेज है. पहला एडवांटेज क्या है? It will also cause vasodilatation, vasoconstriction caused by sympathetic nervous system, उसको ब्लॉक करेगा. दूसरा क्या है? हार्ट रेट को कम करेगा. So that has an advantage. The third drug that I would give is aldosterone को ब्लॉक करना है. So I will give spironolactone. That is the third drug. Nowadays we have started giving a fourth drug जो डायरेक्टली कुछ रिलेटेड नहीं है हार्ट से या इसके पैथोफिजियोलॉजी से, बट स्टडीज आफ्टर स्टडीज हैव शोन दैट वो हार्ट फेलियर के मॉर्टेलिटी को रिड्यूस करता है. व्हाट इज दैट ड्रग? SGLT2 inhibitors, and this had been the examiner's favorite topic in last 1.5 to 2 years. लास्ट 3 और 4 एग्जाम्स में, एवरी एग्जाम, FMG, नीट PG, INICT, कोई भी एग्जाम उठा लो, एक क्वेश्चन रिलेटेड टू SGLT2 इनहिबिटर्स हमेशा आया है. व्हाट पॉइंट्स दे हैव आस्क्ड? वन इज रिलेटेड टू साइड इफेक्ट, राइट? सो हाउ SGLT2 inhibitors work? They inhibit the reabsorption of glucose by the kidneys. नॉर्मली क्या होता है, ग्लोमेरुलाई में हमने फिल्टर किया ग्लूकोज को, राइट? ये ग्लूकोज फिर प्रॉक्सिमल कन्वोल्यूटेड ट्यूब्यूल्स में रीअब्जॉर्ब होता है. रीअब्जॉर्प्शन के लिए हमको चाहिए SGLT2. अगर हमने इसको ब्लॉक किया तो ये ग्लूकोज रीअब्जॉर्ब नहीं होगा, वी विल लूज दैट ग्लूकोज इन यूरिन, हम वो ग्लूकोज को यूरिन में गवा दें. So that is how we can bring down the blood glucose level. So it primarily came into market as an anti-diabetic. But अब किसके लिए यूज कर रहे हैं? Apart from diabetes, we are also using it in patients with chronic kidney disease. We are using it in patients with heart failure. क्यों? Because studies have shown that it reduces the mortality. क्यों mortality reduce करता है? Number one, because we lose glucose in urine. पहला एडवांटेज क्या होगा? When we lose glucose in urine, glucose is also osmotically active substance just like sodium, तो वो अकेला नहीं जाएगा, it will also take water along with that. So when we lose lot of water, we are reducing the preload, right? We are reducing the preload, so that is beneficial to a failing heart. दूसरा क्या है? When you lose glucose, you are passively losing calories, so it will cause weight loss. Weight loss also reduces the burden on the heart, because जितना बड़ा साइज है पेशेंट का, उतना ज़्यादा फोर्सफुली आपके वेंट्रिकल को कॉन्ट्रैक्ट करके ब्लड पहुंचाना पड़ेगा. जितना कम वेट होगा उतना ही बर्डन कम होगा. सो बोथ वेज इट इज बेनिफिशियल टू अ पेशेंट विद हार्ट फेलियर. ओनली वन साइड इफेक्ट दैट इज बॉदरसम, दैट इज बिकॉज वी आर लूजिंग ग्लूकोज इन यूरिन. तो यूरिन में ग्लूकोज ज़्यादा है, so it becomes a good culture media for bacteria. So we are prone to develop bacterial and fungal urinary tract infections. Most commonly in India, we experience fungal urinary tract infections more than bacterial. Okay. अब these are considered as first line medications. तो ये सारे स्टार्ट करते हैं for all patients with heart failure. Usually step by step start करते हैं. First we start with ACE inhibitors, then we add beta blockers and spironolactone and SGLT2 inhibitors, because patient may not tolerate starting all of them together. But in a very quick span of time, all the 4 drugs will be given to the patient, and this is considered as first line medications. अगर इससे काम नहीं बन रहा है, patient continues to be symptomatic, then we add the Neprilysin inhibitor, क्योंकि ये जो हार्मफुल आर्म है उसको तो हमने सब स्क्वीज आउट कर लिया, राइट? सिंपैथेटिक नर्वस सिस्टम को ब्लॉक किया, रास को पूरा ब्लॉक किया, एंजियोटेंसिन 2, अल्डोस्टेरोन सब ब्लॉक किया, बचा क्या है हमारे पास? सिर्फ ये. अब ये बेनिफिशियल है तो मुझे इसको एनहांस करना पड़ेगा. हाउ आई कैन एनहांस? बाय ब्लॉकिंग द नेप्रिलाइसिन. सो वी ऐड नेप्रिलाइसिन इनहिबिटर. नेप्रिलाइसिन इनहिबिटर्स. एग्जाम्पल क्या है नेप्रिलाइसिन इनहिबिटर्स के लिए? सैक्यूबिट्रिल. सैक्यूबिट्रिल. सो ये इज अ दिस इज नॉट अ ड्रग यूज एज अ सोलो थेरेपी. एसी इनहिबिटर्स को हर पेशेंट विद हार्ट फेलियर विद रेड्यूस्ड एजेक्शन फ्रैक्शन को देना है, बीटा ब्लॉकर्स देना है, स्पाइरोनोलैक्टोन देना है, SGLT2 इनहिबिटर्स देना है. उसके साथ में अगर रेस्पॉन्स ठीक नहीं है तो यू कैन ब्रिंग इन नेप्रिलाइसिन इनहिबिटर्स लाइक सैक्यूबिट्रिल. नाउ इट इज कंसिडर्ड एज सेकेंड लाइन ट्रीटमेंट. ओके. Over time, I'm very sure this will become part of the first line medication, because वो benefit जरूर देता है. It also reduces the mortality. So collectively speaking, all these drugs that I've listed here, they reduce mortality. Mortality क्यों reduce कर रहे हैं? Because heart failure के वजह से जो heart में changes हो रहे हैं, we call it as remodeling, cardiac remodeling, वो सब are being countered by these medications. So उसके वजह से हार्ट के काम बहुत इंप्रूव नहीं होगा, लेकिन लॉन्जेविटी बढ़ेगी. सो पेशेंट विल बी एबल टू सर्वाइव लॉन्गर, राइट? सो दैट्स हाउ स्टडीज आफ्टर स्टडीज हैव शोन दैट इट रिड्यूसेस द mortality. Okay. Now please remember one extra point. Sacubitril is available only with valsartan. ये पॉइंट मैं क्यों बता रहा हूं? बिकॉज इट इज अवेलेबल एज अ फिक्सेड डोज कॉम्बिनेशन. सैक्यूबिट्रिल और वैल्सर्टन कॉम्बिनेशन में ही मिलता है, सैक्यूबिट्रिल अलोन नहीं मिलता. तो इफ यू हैव टू ऐड द नेप्रिलाइसिन इनहिबिटर, हमको एक पॉइंट याद रखना, हम एसी इनहिबिटर और ARB देते हैं, एसी इनहिबिटर्स एंड ARB नहीं, दोनों में से किसी एक को, क्योंकि दोनों का मैकेनिज्म अल्टीमेटली सेम ही है. जो एंजियोटेंसिन की इफेक्ट है वैसोकंस्ट्रिक्शन, उसको वो काउंटर कर रहे हैं. दोनों देने से प्रोफाउंड हाइपोटेंशन की रिस्क होती है, तो वी शुडंट बी गिविंग बोथ. क्लियर? सो इन सच केसेस व्हाट शुड वी डू? जो भी पेशेंट एसी इनहिबिटर या एआरबी पहले से ले रहा है, दैट वी शुड स्टॉप बिफोर इनिशिएटिंग दिस सैक्यूबिट्रिल वालसार्टन कॉम्बिनेशन, क्योंकि एआरबी तो आ रहा है इसके साथ, राइट? ओके, so that is the approach. Now question is, बहुत से heart failure patients will also be on diuretics other than spironolactone. उसका रोल क्या है, right? So all these medications reduce mortality. Diuretics improve edema and lung congestion. Edema and lung congestion. तो ये symptomatic के लिए useful है. No impact on mortality. So if you give Lasix, what is that? Is furosemide, right? That has no impact. मतलब mortality को ना ही कम कर रहा है ना ही increase कर रहा है, आपके symptoms better कर रहा है, तो you can give it, no problem. No impact on mortality. In other words, it is mortality neutral. Okay. But कुछ classes of drugs हैं जिसको हम कहते हैं inotropic agents. What inotropic agents do? They stimulate the muscle to contract more so that more can be ejected from the ventricle. तो ये ejection fraction को improve करते हैं. So with that, they will obviously increase the cardiac output and make the patient's symptoms better. But by doing so, ये ventricles जो fail हो रहे हैं उसको और ज़्यादा stimulate कर रहे हैं. They are trying to squeeze more work out of it. It will result in more harmful effects. So studies also have shown that if you give inotropic agents to a patient with heart failure, their mortality risk increases. Symptoms थोड़े better हो जाएंगे, but mortality rate becomes higher. So that is something that you have to remember. The inotropic agents like milrinone or the digoxin. The digoxin used to be the most commonly used drug for patients with heart failure once upon a time. अब नहीं करते. Like digoxin or milrinone, they increase mortality. They, please remember this point. This is a repeatedly tested MCQ point. They increase mortality. Clear? They increase the mortality. Okay, so now last one MCQ point on heart failure, and that is going to be, how can I assess the response to treatment and predict the mortality in a patient with heart failure? एक है ejection fraction. उसके अलावा what else I can do on a routine basis to understand response to treatment, whether patient is heading towards a negative outcome or heading towards a positive outcome? Assessing response to treatment. The best assessment is by looking at the pro-BNP, anti-pro-BNP or BNP levels. अगर anti-pro-BNP or BNP levels are not coming down despite institution of treatment or they are increasing, मतलब ठीक से कुछ काम नहीं चल रहा है, patient is heading towards mortality. But once I start treating, like I give AC inhibitors, ARBs, sacubitril, SGLT2 inhibitors, anti-pro-BNP or BNP levels start reducing, that means patient is responding well to treatment. So how do we assess? By looking at serum BNP or N-terminal pro-BNP levels. N-terminal pro-BNP levels. That is the tool to assess the response to treatment. So that completes a quick discussion on heart failure. I'm getting back to the question and hopefully you should be able to answer it now. What are they asking? We have understood that this patient has heart failure with reduced ejection fraction, EF less than 40%. Now, which of the following medication is indicated for symptomatic relief and mortality reduction in this patient? Okay. So what about digoxin? Will it reduce the mortality? Will it reduce the mortality? No, digoxin actually increases the mortality, right? It is an inotropic agent. Increases mortality. What is milrinone? That is also an inotropic agent, so that also increases the mortality. So not what examiner is asking us. Okay. Then nifedipine is a calcium channel blockers which has nothing directly to do with the patient with heart failure. हम दे सकते हैं अगर patient with heart failure has hypertension और BP control में नहीं आ रहा है, not directly useful for heart failure, right? So neither ये symptoms improve करेगा nor mortality reduce करेगा, right? No role in symptom control or mortality reduction? Carvedilol क्या है? एक beta blocker, right? And beta blockers, the SGLT2 inhibitors, AC inhibitors or ARBs, neprilysin inhibitors, these are the drugs which are known to reduce the mortality as well as improve the symptoms to some extent. So then this will be the answer of choice. This is a beta blocker, and beta blockers reduce the mortality in a patient with heart failure. Okay. Heart failure is a very crucial topic, and all the important points we have addressed here. On that only, there is one more question here, and this is like answer is right in front of you. Which of the following diagnostic test is most useful for assessing the severity of heart failure and monitoring the treatment response? Monitoring the treatment response. 2 points are here. ECG is not useful for the diagnosis of heart failure. Only 2 investigations are useful. And मैंने diagnostic criteria में ही बता दिया है. The criteria for diagnosis actually focuses not on echo. Echo बाद में आता है for classification into low EF or normal EF. तो यहाँ पे तो ये clear है that diagnosis के लिए BNP और pro BNP levels are important. So in that case, what should be the answer here? That is BNP levels. So that is not only useful for diagnosis, but also assess the mortality risk or the prognosis, and also response to treatment. Response to treatment. Clear? Okay. Now we'll go to the next question. A 30-year-old presented with 30-year-old otherwise healthy female presented to emergency department with sudden palpitations, chest discomfort and lightheadedness. On examination, her heart rate is 180. It is regular and there are no other abnormal findings. ECG आपके सामने है. The vagal maneuvers are unsuccessful in terminating her tachycardia. What is the most appropriate initial treatment now? Vagal maneuvers तो हमने कर दिया है. अब next क्या करना है? Look at the ECG first and tell me what is the diagnosis. Then we will approach the case. What should be the diagnosis in this case? Okay, cool. So this is right, PSVT. अब हम कैसे कह सकते हैं कि ये PSVT है? What are the points that makes you think that this is PSVT? See, from cardiology, in the recent times, 2-3 topics have become important. एक है हार्ट फेलियर, दूसरा है अरिथमियाज, वो तो मेरे टाइम से ही इंपॉर्टेंट है हमेशा, एंड तीसरा है सम कार्डियोमायोपैथीज. Nowadays they are asking a lot of questions on cardiomyopathy, so वो तीनों हम एड्रेस करेंगे आज. So what are the points that makes you think that this is a case of PSVT? Okay, so point है कि whenever you get a question on arrhythmia, 2 तरीके के arrhythmias हैं, bradyarrhythmias and tachyarrhythmias. arrhythmia का मतलब है हार्ट का जो रिदम साइनस रिदम नहीं है, then we call it as arrhythmia. Bradyarrhythmias, if they are asking you a question, it is most likely going to be about the AV blocks, the first degree, second degree, Mobitz type 1, Mobitz type 2, and complete heart. And if the question is about tachyarrhythmias, then it is bit more detailed in most cases. अगर ये AV block या bradyarrhythmia के basis में question है, तो they will mostly ask you what is the diagnosis based on the ECG findings. But if it is tachyarrhythmia related questions, they will not only ask you to make a diagnosis. Diagnosis तो आपको दिमाग में बनाना है. They will ask you how do you handle it, या हमने कुछ steps लिया है management में, अगला step क्या होगा? That is the usual question. तो हमको first we should be able to recognize arrhythmia. Second, we should know the protocol of approach to a patient with arrhythmia. So we have to learn approach to arrhythmia. So whenever you have a patient with tachyarrhythmia, मतलब heart rate more than 100, a patient with tachyarrhythmia, the first step that you should take is look into the ECG and see the QRS duration. Like in this ECG, right? What is the QRS duration? What is QRS duration? It begins with the beginning of the Q wave. I am marking it with green. Let me use red color for you to be able to see it. And it ends with the end of S wave. What is the QRS duration? This duration is what we will be calling as QRS duration. Normally, how much it is? It is less than 3 small squares on the ECG or less than 120 milliseconds. One small square on the ECG represents 40 milliseconds, and one large square will have 5 such small squares, so that represents 200 milliseconds. 40 into 5. Okay. Normal QRS should be less than 3 small squares or less than 120 milliseconds. So if it is less than 3 small square and patient has tachyarrhythmia, we will call it as narrow complex tachyarrhythmia. If it is more than 3 small square and patient has got tachycardia, we will call it as wide complex tachyarrhythmia. The first step is to look at the QRS duration. If the QRS duration is less than 120 milliseconds, that is equal to less than 3 small squares on the ECG. From the beginning of Q to the end of S wave, it is taking less than 3 small square. So such arrhythmias, we will call it as narrow complex tachyarrhythmias. Narrow complex tachyarrhythmias. And from the beginning to the end, if it is more than 120 milliseconds, or in other words, more than 3 small squares, we will call such arrhythmias as wide complex. When I say wide, we are referring to the wide QRS complexes. So we call it as wide complex tachyarrhythmias. Okay, so give me examples for narrow complex tachyarrhythmias and examples for wide complex tachyarrhythmias. So please remember, when it comes to wide complex tachyarrhythmias, at the NEET PG level, you have to think of mainly two arrhythmias. One is ventricular tachycardia, other one is ventricular fibrillation. There are some rare conditions where you can have a narrow complex tachyarrhythmia presenting as wide complex tachyarrhythmia, like SVT with aberrancy. That is the purely a NEET SS topic. You don't need to really bother about it. For all practical purpose, हमारे पास दो ही differentials हैं when you have wide QRS complexes. एक है VT, दूसरा है ventricular fibrillation. VT and ventricular fibrillation. Now, when you have narrow complex tachyarrhythmias, you have a wide list of differential diagnoses. So that includes atrial tachycardias, atrial tachycardias, then you have PSVT, and then you have atrial fibrillation. Atrial fibrillation. These three are things. Now, in this atrial tachycardia itself, there are multiple subtypes. Okay. So how do I identify that a particular patient who has got a narrow complex tachyarrhythmia has atrial tachycardia and not PSVT or atrial fibrillation? Like ये जो ECG है, I think all of us can agree here that the QRS duration is barely 1.5 small squares. Let me zoom in and show. Barely 1.5 or maybe 2 small squares, not more than 3 for sure. So this is narrow complex tachyarrhythmia. That is the first point that all of us agree upon. This is a narrow complex tachyarrhythmia. Now in narrow complex tachyarrhythmia, atrial tachycardias, PSVT and atrial fibrillation are possibilities, right? Now, इन तीनों में से कैसे differentiate करूं? I know most of you would say, sir, PSVT and atrial fibrillation are conditions where we will have absent P waves, and atrial tachycardias are conditions where you have P waves present. So whenever we have narrow complex tachyarrhythmia, first thing I should see is what is the status of the P waves. या P waves present हैं or whether P waves are absent. If P waves are present, and what is my differential diagnosis if P waves are absent? P waves are absent. So please remember now, if P waves are present, there are two possibilities. First one, it may be normal sinus tachycardia. Means, see, right now I'm taking a class. After this, if I run around this hall for 2 minutes and then come back and sit, my heart rate will go more than 100. Do I have arrhythmia? No, I have sinus tachycardia. Normal sinus rhythm, but heart rate is increased because my adrenaline is firing up. How the ECG is going to look like? Normal ECG, but increased heart. So P waves normal ECG में होते हैं, तो यहाँ पे भी होंगे. तो एक differential diagnosis होगा sinus tachycardia. Sinus tachycardia, and the next differential diagnosis will be atrial tachycardia. Atrial tachycardia, basically look at the name of the disease itself. So it is saying that we have atrial tachycardia. So SA node we have in the atrium, then we have the AV node. So यहाँ पे SA node is not becoming the pacemaker. Something else has become the pacemaker, and that is making the atria contract vigorously at higher rate. Normally, when SA node sends the signals to atria to contract, it sends at a rate of 60 to 100. That is why our normal heart rate ranges from 60 to 100. Okay. So if atria is the foci, it is getting depolarized. When atria becomes depolarized, we will have P waves. When SA node sends the signal, atria is getting depolarized, we will have P waves. Then how do I differentiate between the two? Please remember, in sinus tachycardia, the number of P waves, the number of P waves will be equal to the number of QRS complex. Number of P will be equal to number of QRS. Because in sinus tachycardia, what happens? SA node only is sending the signal to the atria at higher rate because it is under the influence of adrenal, higher rate. Now what will happen? All that higher rate will also reach the AV node, and AV node will send that signal down through the his bundle Purkinje fibers to ventricles to contract. So when ventricles get depolarized, I will have QRS. When atria get depolarized, I will have P. जितना बार atria depolarize होगा उतना बार ventricle will also be depolarized. So the number of P waves will be equal to number of QRS. So take any rhythm stick. Behind every QRS there will be a P. After P there will always be a QRS. But in atrial tachycardia, what happens? If atria starts sending signals, your SA node is also sending to the AV node. Now, do you think AV node will respond to all the signals? No, right? So if atria sends 3 and SA node send one signal in 1 second, maybe AV node will send 2 signals coming from the atria and 1 coming from the SA node. So we have 3 going down to the ventricle. But how many times atria contracted? 4. How many times ventricle contracted? 3. So all that extra atrial rate need not always be transferred to ventricle. So then in that case, what will happen? Atria is contracting more than ventricle. So number of P waves will be more than number of QRS complexes. So take a narrow complex tachyarrhythmia and see whether P waves are present or absent. Present hai, and every P is followed by a QRS, you have a sinus tachycardia. But you see more P waves, not all of them are becoming QRS. Some of them are becoming QRS, some of them are like followed by another P wave only. Then you have atrial tachycardia. Now in atrial tachycardia itself, you have some subtypes. You have to be aware about 2 subtypes, right? Important subtypes. So 2 important subtypes you should be aware of. The first one is called as multifocal atrial tachycardia. Multifocal atrial tachycardia. Now look at the name. What is the name? Multifocal atrial. Atrial tachycardia hai. So when we say atrial tachycardia, we understand that P waves are more than the QRS complex. That's why atrial rate is higher than the ventricular rate. Why are we calling it as multifocal? Because it is not one portion of the atrium which is triggering. Multiple areas of the atria have become the pacemakers apart from your SA node. Right? So then your SA node is sending signal to AV node, but apart from that, let me say 1, 2, 3, 4. These 4 foci have become pacemakers. So they are also sending the signal to the AV node. Do you think the P waves produced by all the signals will look the same? No, the P wave produced by the SA node will have this normal upright appearance. Okay. The P wave produced by a node closer to the AV, which is causing retrograde conduction, means here is a focus. So this focus will send the depolarization through atria like this instead of coming from top to bottom. So now what will happen? The P wave will become inverted because the direction of flow is not like this, but in the opposite direction because the focus is here. So now what happens? I see different looking P waves. So in an ECG, if the number of P waves is greater than QRS and we have more than or equal to 3 different P wave morphologies, then we will call it as multifocal atrial tachycardia. So take any ECG, heart rate more than 100, we have tachycardia. See whether P is present or absent. Present hai, and it looks like there are more number of P waves than the QRS complexes, and her P alag hi dikh raha hai, it doesn't look same. Then it is multifocal atrial tachycardia. Why this is examiner's favorite? This is examiner's favorite because this multifocal atrial tachycardia that I am talking about is the pathognomonic arrhythmia of patients with COPD. It is the pathognomonic arrhythmia of patients with COPD. That means what? This arrhythmia is generally not seen in non-COPD patients. It is only or most likely seen only in patients with COPD patients. That's why we call it as pathognomonic arrhythmia of COPD. Arrhythmia of COPD. Okay. So that is one subtype. Then we have a second subtype. In the second subtype, it is a typical atrial tachycardia, but atrial rate is way higher than the ventricular rate. So when atria beats 5-6 times, then ventricle, only one of that atrial depolarization wave is reaching ventricle, resulting in QRS. So how the ECG is going to look like? Too many atrial contractions, okay, followed by one ventricular depolarization, and again too many ventricular contraction followed by one ventricular depolarization. So now how this ECG looks? So when you look at this ECG, right, first thing that comes to our mind is the appearance of a sawtooth. So what arrhythmia it is? When we have this sawtooth appearance, we call it as atrial flutter. So basically, atrial flutter is a type of atrial tachycardia where atrial rate is too high. See, if atrial rate is like conduction is 2:1, it may not look like the sawtooth appearance. But when there are too many atrial contractions followed by one ventricular contraction, the whole ECG starts looking like sawtooth. So we call it as atrial fibrillation. Atrial fibrillation, characteristically called as sawtooth appearance. Sawtooth appearance. Okay. Now, if the P waves are absent, then the sinus tachycardia, atrial tachycardia are out from the scene. These two possibilities are out. We are left with two other possibilities, that is PSVT and atrial fibrillation. How do I differentiate between the two? So all you have to see is the QR interval. The RR interval between two R waves, whatever space is there, that is the RR interval. Whether it is constant or there is beat to beat variation. So you have to look at the RR interval. If the RR interval is constant, that clearly means that you're dealing with a patient with PSVT. And if the RR interval is varying, then you are dealing with a patient with atrial fibrillation. Okay, so with that clarity, let us get back to this question. We are dealing with an arrhythmia. First thing we should see is the rate. This clearly has tachycardia because in the question also they have mentioned the rate. So in that case, no need to waste time calculating the rate. अगर question में mention नहीं किया है तो we can calculate from the ECG. So here roughly between the two RR waves, I have around 5 small square or 1 large square. So 300 divided by 1 large square. I get a heart rate close to 300. Okay, so tachycardia is there. Question they have mentioned 180. So from there only I have already understood. But if required, I can calculate from the ECG. Now I know that this is a tachyarrhythmia. What is my next step? Look at the QRS complexes. So when I look at it, the duration is less than 3 small square. So this is narrow complex tachycardia. So once I have narrow complex tachycardia, according to our protocol, what is the next step? I have to see whether P waves are present or absent. Now, what do you think in this patient? Do we have P waves or not? So the supraventricular arrhythmia with aberrancy can also present as broad complex tachyarrhythmias. And Torsades D-pointis is a subtype of ventricular tachycardia. I'll talk about it. So in this case, P waves are present or absent. What do you think? So again, in the exam hall, we can have this one confusion that I see some positive wave other than QRS. Is that P or T? Right? Is that P or is it T? ये क्या है? So please remember, generally, absolutely undiscernible absent P waves is rare. Normally, P waves के साथ क्या हो सकता है? They can become tall, right? They can become partially flattened or they can become inverted. You know, in ischemic heart disease, you can have inverted T waves. In hyperkalemia or acute phase of MI, you can have tall T waves. In ischemic heart disease, you can have slightly flattened T waves. But completely absent T waves is a bit unusual, right? So what you should do is, whenever you get an ECG where you are in doubt whether I have P wave or T wave, First, because T wave absency is less likely, label anything that you see other than QRS as possible T waves. इसके अलावा और एक पॉजिटिव वेव बच जाता है, then I will call it as P wave. अगर नहीं बचता है तो that means there is no P wave. So in this case, all of these, if I label them as T wave, then there is nothing else for me to label as P wave. So I will take it as absent P waves. So this is a narrow complex tachyarrhythmia with absent P waves. Absent P waves. And when we have narrow complex tachyarrhythmia with absent P waves, what is the next step? We have to see the RR interval, whether it is constant or there is beat to beat variation. So here we can clearly see, just one quick look, that it appears constant. So what is our diagnosis here? We have constant RR interval. So that makes the diagnosis as PSVT. Right. Now question is, how do we manage a case of PSVT? I've given you the approach for all the narrow complex tachyarrhythmias. So we will quickly study about management of PSVT before we go to the next question. PSVT is a prototype example for a narrow complex tachyarrhythmia. So how do we manage? So management of PSVT will take into account, the first step when you deal with a patient with PSVT is look at their blood pressure. Look at their blood pressure. Now, if the blood pressure is less than 90/60, less than 90/60 millimeters of mercury, this is clearly a hemodynamically unstable. So sometimes in the question, instead of giving the BP, they will mention hemodynamically unstable patient. Hemodynamically unstable. In such cases, right, whenever any arrhythmia, any tachyarrhythmia, if the BP is low, directly एक ही treatment है, and that is going to be to give the shock. Now shock has two types. We call it as cardioversion and defibrillation. So which type of shock I should follow here? Cardioversion or defibrillation? Which type of shock I should follow here? Hemodynamically unstable, वो VT हो, VF हो, PSVT हो, या atrial tachycardia हो, atrial fibrillation हो, BP लो है, तो पहला step है to give the shock. No time wasting giving pharmacotherapy. But there are two types of shock, right? Cardioversion and defibrillation. So what should we give here? So please remember now, because there is lack of time, I'm not getting into the details of difference between cardioversion and the defibrillation. But I'll tell you which circumstances we use defibrillation, which circumstances we use cardioversion. Right? So we'll put a small table here for that. Where do you follow the cardioversion? Where do you follow defibrillation? So defibrillation is followed in two conditions. What are those? First one, when you have ventricular fibrillation. And the second condition where we follow defibrillation is when you have a ventricular tachycardia in a scenario where pulse is not felt. Ventricular tachycardia with no pulse, or pulseless VT, as we call it as pulseless VT. Pulseless ventricular tachycardia. And where do we follow cardioversion? Cardioversion is followed for any patient who has narrow complex tachycardias whose BP is unstable, right? So this is followed for all narrow complex tachyarrhythmia, that includes your PSVT, atrial fibrillation, atrial tachycardias, all of them. Okay. Apart from that, cardioversion is also followed for VT with pulse. VT with pulse. So I want you to remember or memorize this table. This will definitely come in handy. So obviously in patients with PSVT, we are going for cardioversion. But if the patient is hemodynamically stable, that is BP more than 90/60, right? In other words, hemodynamically stable patients. In such patients, we directly do not go for shock. We can go for pharmacotherapy. But supraventricular arrhythmias have a tendency to respond to activation of the vagus nerve. So how can I activate the vagus nerve? There are various mechanisms. We collectively call them as vagal maneuvers. So if the patient is hemodynamically stable, right? So first step will be to do vagal maneuvers. Vagal maneuvers. What are the vagal maneuvers we should be aware of? There is Valsalva maneuver, right? Modified Valsalva maneuver, or the carotid massage. So you can follow any of them, like carotid massage or Valsalva. If that fails to correct the arrhythmia, then next step will be to go for pharmacotherapy. What is the drug of choice? The drug of choice for PSVT is pharmacotherapy. The drug of choice for PSVT, as most of you mentioned, it is going to be adenosine. It is going to be adenosine, right? What is the route? IV, preferably through central line. And what is the dose? The first dose that we give is going to be 6 milligram. 6 milligram से काम नहीं बनता है, patient continues to be in PSVT, then we can repeat 2 more dose. Second and third dose we can give 12 milligrams. 12 milligrams each, 12 mg each. अगर उससे भी काम नहीं बन जाता है, means we are still in PSVT, then we have to go for again cardioversion. Cardioversion. Now you have to be aware of one important side effect of adenosine. It is the bronchoconstrictor. So this can cause indeed precipitation of asthma or COPD. So that is why it is better avoided in patients with asthma particularly, and you have to exert a caution in patients with COPD too, because it is a bronchoconstrictor. Okay, so now coming back to the question. I think all of us made the diagnosis of PSVT. Then they have already made this initial step, that is vagal maneuvers. So from this I can understand that patient was hemodynamically stable, तभी तो ये vagal maneuvers ये सब चक्कर में पड़ रहे हैं. BP was low तो directly cardioversion को चले जाते हैं. Vagal maneuvers have done, it is unsuccessful. What is the most appropriate treatment now? What is the most appropriate treatment? So obviously I think all of you mentioned the right answer. That is going to be intravenous adenosine. Intravenous adenosine, preferably given through central line, because the half-life of adenosine is very low. But now, if I bring in a twist and mention that otherwise healthy female, I cut it and I mention that the patient is asthmatic. In that case, what will be our drug of choice? In that case, what will be our drug of choice? So we just learned, right, that adenosine is contraindicated. Contraindicated in asthma, right? So in such cases, alternative क्या है हमारे पास? We mainly use the calcium channel blockers. What kind of calcium channel blockers? There are two types of calcium channel blockers: dihydropyridine calcium channel blockers, non-dihydropyridine calcium channel blockers. So we primarily use non-dihydropyridine calcium channel blockers like verapamil or diltiazem, or other alternative that we can use is amiodarone or amiodarone. So if I change this patient story, that patient is asthmatic, then the next option would be intravenous calcium channel blockers like verapamil or diltiazem, right? So that is our approach to a patient with narrow complex tachyarrhythmia. यही template आप follow करेंगे for all narrow complex tachyarrhythmias. Okay, except that vagal maneuvers have limited role in rest of the narrow complex tachyarrhythmias. Okay, so we have another question here. A 55-year-old female with history of heart failure presents with sudden cardiac arrest. An initial rhythm strip shows irregular, rapid, and chaotic QRS complexes. Which of the following is the most appropriate initial step in the management? Okay, so this is the ECG. We will come back to the initial step, but I want you to go through the ECG and tell me what is your diagnosis. Okay, so whenever we have, see, one quick look only, we can tell that heart rate is quite high, right? Heart rate is quite high, because what is the RR interval? It is not even one large square. So 300 divided by 0.8 or something. So it is 300 plus heart rate is for sure. Okay. Now, what is the QRS duration here? Look at the QRS duration. QRS duration is certainly more than 3 small squares. So we are dealing with wide complex tachyarrhythmia, right? So we are dealing with wide complex tachyarrhythmia. Tachyarrhythmia hai, we agreed, and QRS duration is wide. So it is a case of wide complex tachyarrhythmia. What are our differential diagnoses for wide complex tachyarrhythmia? Ventricular tachycardia, ventricular fibrillation, and as some of you had mentioned, the supraventricular tachyarrhythmias like atrial fibrillation or PSVT with aberrancy. Now, just because we're talking about it, I'll tell you what this aberrancy means. I will give you an example. You may be familiar with this WPW syndrome, right? WPW syndrome में क्या होता है? You have a extra connection that is kind of conducting the impulse faster from SA node to AV node. There is a normal conducting pathway. There are 3 internodal tracts. But in these patients, there is an accessory extra pathway which is conducting the impulses faster, तो SA नोड से AV नोड तक या AV नोड से आगे हिस बंडल तक impulse is being conducted faster, and that is why in WPW syndrome we have short PR interval. Okay, but this faster conduction actually delays the travel of the impulse through the ventricle and makes the QRS duration wide. So WPW syndrome में PR interval is short. Then you have this wave called as delta wave. The R wave upstroke has a slant. Okay, so you will have a very short PR interval. There is a slant to R wave upstroke. So this slant is what you call as delta wave. And then you have this wide QRS complexes, and then you may have an inverted T wave. These are the important changes, right, that we see in WPW syndrome. The third finding you have here is wide QRS complexes. So QRS complexes in WPW are already wide. Now, suppose this patient develops an atrial fibrillation or a PSVT, how the outcome will be? Will I get a narrow complex tachyarrhythmia? No, क्योंकि QRS complex already wide है, तो tachyarrhythmia wide में ही रहेगा. Actually, origin कहाँ पे है? Supraventricle में है, above the ventricle है, but it looks like the other causes of ventricular arrhythmia like VT or VM. So such conditions we call it as SVT or supraventricular tachyarrhythmias with aberrance. Okay. Now, differentiating this from ventricular arrhythmias is a difficult task. It is primarily a PG topic, so you don't need to bother about it. So, इस ECG में clearly we have wide complex tachyarrhythmia. Now, how do I approach the diagnosis of a wide complex tachyarrhythmia? Right. So, what you have to do is when you have a patient with wide complex tachyarrhythmia, first thing you have to see is whether the QRS complexes look same or they look different. Okay. So, if they're looking same, then it is most likely going to be a type of ventricular tachycardia. Okay, I will show you some image, or let me draw it. So if the complexes are wide and they kind of look same, morphology wise they are same, such a ventricular tachycardia is called as monomorphic VT. So when you look at the name only, it tells mono, single morphology, right? So we call it as monomorphic VT. Now if I have wide complex tachyarrhythmias, but complexes look different, they don't look same, they look different, then we call it as polymorphic VT. Polymorphic VT. Okay. Now something similar is seen where the complexes look different. They are wide, but they look different. We call that as ventricular fibrillation. Ventricular fibrillation. It's not very difficult for us to recognize the monomorphic VT, right? Wide QRS complexes, all the complexes looking same. Let me see if I have a ECG. Okay, so now look at this ECG. You can clearly see that all the complexes look same. Now you may be saying that, sir, all these complexes look different from these. Please, when I say all the complexes look same, I'm referring to one given lead. Normal ECG में भी all the complexes don't look same in all the leads. वो अलग-अलग ही दिखते हैं अलग-अलग leads में, because the leads are looking at the heart from different locations. They are going to look different. But किसी एक lead को पकड़ लो, they all look same. Normal में भी, and in monomorphic VT, you have these wide complexes which are looking same in any given lead, right? V1 में they are all looking same. V4 में they are all looking same. V5 में they are all looking same. This is what we call as monomorphic VT. So that is very easy to identify. Now, what is difficult to differentiate is the polymorphic VT and ventricular fibrillation. मैंने sketch बना के दिखाया, right? So what is the main difference here? दोनों complex are looking different. The main difference is the amplitude. So when you look at the ECG, if the QRS amplitude means the height of the QRS complex appears like any normal ECG, but they are wide and looking different, then take it as polymorphic VT. But if the QRS amplitude is very small, then take it as ventricular fibrillation. See, when you use the word fibrillation, इसका मतलब क्या है? Ventricle is shaking, not contracting. That's a basic understanding. Fibrillation means shaking, not contracting. Shake क्यों कर रहा है? Because it is not getting the sufficient voltage enough to generate a contraction. जितना contraction मिल रहा है उससे shake कर रहा है. कितना voltage मिल रहा है? बहुत कम मिल रहा है. So that is why you are getting these small QRS complexes. Okay. So now looking at the ECG in question, do you think these QRS amplitude look normal? They are pretty small only, right? So what should be our diagnosis here? We will take it as ventricular fibrillation. This patient has got ventricular fibrillation. Okay. Now there's a point to note here. There's a subtype of polymorphic VT. a subtype of polymorphic VT in which the QRS complex is obviously going to look different, but the QRS amplitude varies in such a way that the whole arrangement of complexes looks like there is an axis around which the QRS complexes are twisting. What do we call it as? We call it as Torsades d pointis. So Torsades d pointis, please remember, is a subtype of polymorphic ventricular tachycardia. So this is how it kind of looks like. The complexes look like they are creating a waveform, right? अगर एक बीच में axis होता तो it looks like a coil is twisting around the axis. Torsades means twisting. So this type of ECG is what we call as Torsades d pointis. And Torsades d pointis typically happens when the ventricular tachycardia originates at the backdrop of previously elongated QT interval. QT interval. We call it as Torsades d pointis. D pointis. So what are we noticing here? QRS complexes are wide. The morphology of the complex are not looking same in a given lead, and they're not only just looking different like any other case of polymorphic VT, but the arrangement of QRS complex such that we are creating a waveform, right? यही तो हम करते थे ना physics में when we draw the waveform. So it is kind of looking like that. Yeah, जो DNA का structure है, kind of that. We call it as Torsades d pointis. And Torsades d pointis typically happens when there is it is usually due to prolonged QT interval. So what all conditions can cause prolonged QT interval? You have congenital QT syndrome, but most commonly prolongation in QT interval happens because of drugs like the macrolides, azithromycin, and then quinolones. Okay, then a lot of other antiarrhythmic drugs, and apart from that, quinine, which is used for treatment of malaria in pregnancy. So they are all known to cause QT interval prolongation, and they can trigger the Torsades d pointis. Okay, so that is about our broad complex tachyarrhythmia. So from the question, we clearly understood that we are dealing with a case of ventricular fibrillation. In this question, we are dealing with a case of ventricular fibrillation, and they have also mentioned irregular, rapid, chaotic QRS complexes. Okay. So now how do I manage this case? What should be my next step? So let us learn about the approach to wide complex tachyarrhythmias. Approach to wide complex tachyarrhythmias. I will divide these wide complex tachyarrhythmias into two groups. The first one is ventricular fibrillation. The second one is ventricular tachycardia. Ventricular fibrillation and ventricular tachycardia. Now, when it comes to ventricular fibrillation, it's a grave danger, because what does that mean? Ventricle is merely shaking, not contracting. So if it is not contracting, it is not ejecting the blood. So almost always patients with ventricular fibrillation, when you see them, they will be pulseless. They won't have any pulse because ventricle is not contracting. जो ECG में हम waveform देख रहे हैं with small amplitude, that is not sufficient enough to trigger a contraction. So shaking, no flow of blood from the ventricle to the aorta, no pulse. Within few seconds, few minutes, patient is going to be brain dead, eventually die. So it is a grave danger. Now, equally dangerous would be a ventricular tachycardia with no pulse, or in simple words, pulseless VT. Pulseless VT. Okay. Then ventricular tachycardia with pulse, I will put it in a separate category. Pulse है तो मतलब क्या है? You are able to give at least some amount of output from the ventricles. Okay. Now, in these patients, what should be my first step? See, there are two questions that they will ask. What is the treatment of choice for these patients, and what is the first step in their management? So you suddenly see someone that is collapsed. You don't feel any pulse. What do you do next? So the treatment of choice, agar pucha jayega, so then the answer will be different. And the first step in the management, when they ask, the answer is going to be different. First step is, because the patient does not have pulse, obviously it means that he is not getting the blood to brain. His brain is dying. So to save the brain, we have to initiate CPR, right? Immediate CPR. Start the CPR, keep doing the CPR, and then seek help or get the defibrillator, because the treatment of choice for this condition, I think we made a table there, that is defibrillation. Defibrillation. We need to do defibrillation as soon as possible, but tab tak CPR, as soon as you recognize that this is VF or pulseless VT, we have to start CPR. But if it is ventricular tachycardia with pulse, then we follow the same approach that we followed for the narrow complex tachyarrhythmias. Like we will look at the BP of the person. If the BP of the person is less than 90/60, as we know, we have to go for shock. And what kind of shock? We just made a table here, right? So if it is VT with pulse, we go for cardioversion. VT without pulse, we go for defibrillation. So we will go for cardioversion. Cardioversion. And if the BP is more than 90/60, so patient stable hai, we can go for pharmacotherapy. Pharmacotherapy. So the first question they will ask you is what is the drug of choice? So आज के टाइम पे currently the drug of choice is amiodarone. Amiodarone, right? As an alternative, if you want to use, we can consider lignocaine. But if this VT with pulse is indeed because of Torsades D pointis, if it is Torsades D pointis, then what will be the drug of choice? In that case, the drug of choice will be magnesium sulfate, something which has been repeatedly asked as an MCQ. What is the drug of choice for a patient with Torsades D pointis? That is going to be magnesium sulfate. So now getting back to the question, what should be our answer here? This is a patient with wide complex tachyarrhythmia, right? Varying QRS morphology. So certainly this is not monomorphic ventricular tachycardia, and it has low QRS amplitude. So all of that makes it a typical case of ventricular fibrillation. And when we have ventricular fibrillation, start CPR, and as soon as you have the defibrillator, defibrillate. So what is the first step here? Immediate initiation of CPR. That would be the answer. But please remember, look at the wordings of the examiner. So if the examiner says, what is the treatment of choice for this condition? CPR is not treating the arrhythmia. CPR is only trying to keep the brain alive till we solve the arrhythmia. So CPR is the first important step. The treatment of choice will be defibrillation. Clear? Okay, so we'll go to the next question now. So in this question, we have a 65-year-old post-menopausal woman presents to the emergency department with sudden onset chest pain and shortness of breath following an intense emotional stressor. कुछ भी हो सकता है, not being judgmental here. Maybe बेटे ने एग्जाम में फेल कर दिया, कुछ whatever, some intense emotional stressor. She has a history of hypertension but no prior cardiac issues. On examination, she appears distressed. Her blood pressure is elevated. Cardiac auscultation reveals a new systolic murmur. ECG shows ST elevation in anterior leads. Troponin levels are mildly elevated. So अब तक आपके दिमाग में क्या diagnosis है? What is the diagnosis you're thinking of? So from the story, it looks like, see, some bad news. After that, patient has experienced chest pain and shortness of breath. ECG is showing ST elevation in anterior leads. Troponin B positive hai. So we are thinking that this could be a case of anterior wall MI. But when I lead further, I get to know that the echocardiography reveals apical ballooning with preserved basal function. Which of the following is the most likely diagnosis? So this apical ballooning is the telltale clue here. It says what is the diagnosis. So what is the diagnosis here? This is one of the myocardial infarction mimickers. So it mimics like MI, but patient does not have MI. So one such mimicker is Prinzmetal's angina. Another is aortic dissection. And one more is stress cardiomyopathy or Takotsubo cardiomyopathy. So what should, right, all of you are right. So this story goes in favor of the diagnosis of Takotsubo cardiomyopathy. If I eliminate this statement, apical ballooning, and I mention that instead there is regional wall motion abnormalities, the ventricle movement is abnormal, not apical ballooning, then it will become a case of anterior myocardial infarction. Okay, so few points about this stress cardiomyopathy, or stress cardiomyopathy is also called as this is a repeatedly asked topic, so that is why we were discussing few minutes on it. Okay, so this is also known as, why this is important, because instead of calling it a stress cardiomyopathy. Options एग्जाम में वो हो सकते हैं which you are not familiar with. Right? So this is also known as apical ballooning syndrome. Ballooning syndrome. The condition is also known as broken heart syndrome. Broken heart syndrome. The condition is also known as Takotsubo cardiomyopathy. Takotsubo cardiomyopathy. So it is an acute cardiac muscle disorder where cardiac muscles significantly lose their function acutely upon exposure to a stressful event. And when I say this stressful event, it could be physical or emotional, most commonly emotional. अब ऐसा क्या होता है on getting an emotional stressful trigger that heart loses its function? Okay. So what happens basically in stress cardiomyopathy is upon hearing a intense emotional stressor or a physical stressor, intense emotional or physical stressor. See, what are adaptations that we suddenly go through when we hear stress? जैसे कि हाँ, okay, so you're listening to the class, then suddenly you realize that there is a cobra lurking underneath your feet. That is a sudden stress to the body, right? So what all adaptations body triggers? आपके reflexes तो obviously will withdraw your legs and all. Apart from that, you're activating the stress responding hormones, so which includes your cortisol and the sympathetic nervous system, that is adrenaline, right? So this sometimes this intense emotional stress can intensely activate intense activation of sympathetic nervous system. And when sympathetic nervous system gets activated, we release what all hormonal mediators. Collectively, we call them as catecholamines, right? We call them as catecholamines. So that includes adrenaline, noradrenaline, and dopamine, right? So we release catecholamine surge. Large quantity of catecholamine release, we call it as surge. So that includes our adrenaline, noradrenaline, and dopamine. Okay, so now what this sudden burst of catecholamines will cause to the heart? It will overstimulate the heart. It will hyperstimulate the heart. So when hyperstimulation of the heart happens, what will happen to the heart rate and the force of contraction of the heart under the influence of adrenaline? Both will increase. Heart rate increases and the force of contraction increases. Now just imagine you go to the gym, take a dumbbell and start doing your biceps curls. How long you can go on? There is a limit, right? Suddenly 15 kilo ka hota hai, you lift 15 kgs and start doing the biceps curls. After doing some 10, 15, maybe 20, 25 repeated movements, you will no longer be able to do the movement at all. For the movement, muscle contraction, we need ATPs, which muscle would have a reasonable store of glycogen, glucose, and ATPs. So it starts spending that ATPs. It starts producing more ATPs from glucose and glycogen. And as long as it has adequate supply of ATPs, it will be able to contract. But once all the ATPs are exhausted, will it be able to contract anymore? That is where we reach the failure point. We can't lift the dumbbell anymore. Same is happening to heart. So when we hyperstimulate heart, it is contracting vigorously at very high rate. So during that period, it is using ATPs like anything. So once all the stored ATPs in the cardiac myocytes are exhausted, now will it be able to contract well? No, just like the biceps, this also loses its ability to contract. So this hyperstimulation leads to expenditure of energy reserve. Expenditure of energy reserve. Energy reserve. And that results in myocardial stunning, means reduced contractility. Myocardial stunning. And see, for cells to survive, forget contract, survival के लिए भी they need ATP. So if there is no sufficient ATP, some cells will start dying. So when myocardial cells start dying, and it can lead to myocardial cell death. So myocardial stunning will lead to decrease in ejection fraction, decrease in stroke volume, and that will result in symptoms of heart failure. symptoms of heart failure. And the myocardial cell death result in features suggestive of myocardial infarction and rise in troponins. There is no ischemia here, but we are getting the similar symptoms. That is the outcome. Okay. Now the point is, why are we calling it as broken heart syndrome? That is pretty straightforward. In the past, most of these cases used to get recognized typically following proposal and then being rejected. Like the guy proposes and the girl rejects it. So dil toot gaya, heartbroken, sudden surge of like rejection was not expected. So sudden surge of all this adrenaline, noradrenaline, heart gone. So that's why we used to call it as broken heart syndrome. Now, why we call it as apical ballooning syndrome or Takotsubo cardiomyopathy? So one point we have to understand is that hyperstimulation of the heart does not affect your whole of the ventricle uniformly. It affects disuniformly. So when you look at the anatomy of the ventricle, this is how the ventricle looks like. This is your atrium, and then this is your aorta. This is where you have the aortic valve. Okay. So now there is a portion of the ventricle, this portion which I am labeling in blue. This is called as left ventricular outflow tract. We call it as LVOT because the blood is flowing out from the left ventricle into aorta through this region. So we call it as left ventricular outflow tract. And then whatever region I am labeling in pink, right? This is what we call as the apex of the left ventricle. Okay. Then rest of the left ventricle, we will call it as base of the left ventricle. Now, so please remember the adrenaline receptors have the highest density in the region of left ventricular outflow tract. Then second highest density at the base and the least density at the apex. So imagine a balloon. Think that this is a balloon. Okay. And this is the opening. Okay. Now, if I send too much of adrenaline and stimulate all these receptors, because receptor density at LVOT is very high. So this area will go into intense contraction. So when this area contracts, will it allow the flow of blood out? No. So it creates an obstruction. This area is also intensely contracting because next highest density of adrenaline receptors is here. This is the area where we have the least amount of adrenaline. So this is not being much stimulated. So when pressure starts building inside the ventricle, this pressure cannot be vented out towards the aorta because this area is fully contracted and blocking. So all the pressure gets channelized towards the apex. Now under this pressure, apex will form a balloon. It will pop out like a balloon. And that is why we have started calling it as apical ballooning syndrome. If you've seen an echocardiography video, you will clearly see that during systole, the apex comes out like a balloon. So that's why we call it as apical ballooning syndrome. Apex becoming like a balloon. Now, when you look at the ventricular shape, right? So this ventricle kind of looks like the pot used by the Japanese people to catch an octopus. The pot is called as Takotsubo. So we called it as Takotsubo cardiomyopathy. Clear? So these are potential clues: apical ballooning on the echocardiography or appearance of the left ventricle like the Takotsubo pot means that you're dealing with stress cardiomyopathy. So because they mentioned it here as apical ballooning syndrome, we will take it as the diagnosis suggestive of Takotsubo cardiomyopathy. Now last point is, how do I treat these patients? What is the most important fear I would have? Patients would have developed sudden heart failure, right? Because myocardium is not contracting, so pressure inside the ventricle is going up. Okay. And then pressure inside the atria is building up. So blood flowing from the lungs to the left atrium is impaired. So all the blood is getting collected or pooled in the lungs. That's what we call as pulmonary congestion. And we have dyspnea. Second, now that all this happened, ventricular muscle has expended all energy. Now they are unable to contract well. So their amount of blood ejected is coming down. So BP is coming down. These are the concerns. Now, how do I treat it? Okay. So when you go to the gym and start lifting the dumbbells, you reach a failure point because all your ATPs are gone. If I give rest to the biceps muscle for a few minutes, can I start it again? Can I start lifting the dumbbells again? Perfectly fine, right? That is what we do in the gym. We take breaks in between the sets so that we charge up our muscle and then we are able to do it again. So same thing we have to do for the ventricle. So when ventricles, we facilitate more production of the ATPs, they will bounce back. All the abnormalities will revert. But how can I facilitate increased production of the ATPs? ATP production बढ़ाने के लिए ventricles को I have to give more glucose and other raw materials required. How can I give it to the ventricle? It has to receive it from the coronary arteries. Coronary arteries originate from the ventricles, means originate from the aorta, and blood to the aorta comes from the ventricle. If ventricle is not sufficiently sending the blood to aorta, then sufficient blood is not coming to the ventricles also. So then now we are in a vicious cycle. How can I break the cycle? What we do is we put a small pump inside the aorta called as intra-aortic balloon pump. And what we do is this pump gets inflated during diastole. So when it gets inflated, right, pressure inside the aorta starts increasing, and because of that pressure, blood flow through the coronaries to the ventricle improves. So we start giving more blood to the ventricle. Ventricles will start taking more glucose, generate more ATPs, and then they will bounce back. So what is the treatment of choice? The treatment of choice will be intra-aortic balloon pump. The treatment will be intra-aortic balloon pump. One point to remember here: if the BP is low, how do I treat? Still with intra-aortic balloon pump. Let the heart recover. It will do its job after that. If you give inotropes, we will worsen the condition, because ये problem शुरू क्यों हुआ था? Because of the catecholamines, and most of our inotropes are adrenaline, noradrenaline, dopamine, यही तो देते हैं. So it will worsen the condition. So please remember, inotropes are to be avoided. Avoid inotropes because they will worsen the condition. Okay, so that's about our Takotsubo or stress cardiomyopathy. Let me see if I have any image of the Takotsubo. So when you see this image, you can probably understand. Look at this left ventricle. So normally left ventricle is kind of conical. It looks like this. But here, because the apex is widened and ballooned out, so it kind of now looks like this Japanese spot, right? So this spot is what we call as Takotsubo, and this is how the ventricle looks like. Clear? So I think this illustration gives you an idea. The left ventricular outflow tract is vigorously contracted. The base is contracting, pushing the apex out to form a balloon. Okay. Now let's go to the next question. A 70-year-old woman with history of recent emotional stress presents with acute onset chest pain and dyspnea. She is hemodynamically stable with no significant past medical history except well-controlled hypertension. ECG shows T wave inversion. Okay. I think it is the repetition of the same question, so rather I will move to the next question. A 60-year-old woman presents with 6 months history of worsening shortness of breath and non-productive cough. She has a history of connective tissue disease. On examination, she has digital clubbing and bibasilar fine inspiratory crackles. Her HRCT shows bilateral ground glass opacities and reticular changes with honeycombing in lower lobes. Pulmonary function tests reveal restrictive pattern with decreased DLCO. Which of the following is the most likely diagnosis? So what do you think should be the diagnosis here? Heartbreak myopathy. Yeah, see, today's time, if I would have discovered this disease, I would have rather called the Takotsubo cardiomyopathy as moe disease. मतलब propose किया moe हुआ फिर heart चला गया, right? That would have been the most appropriate name. But we can't do that because there is a similar sounding name, disease called as moya disease, which you might have studied in pediatrics. Okay. So what is the diagnosis here? How do we approach a respiratory disorder? There are different ways, but the common way is differentiate a respiratory disorder into two groups. The restrictive disorders, where there is restriction to the lung movement, or the obstructive disorders, where there is obstruction to the airflow to the lungs, right? And what are the tools that help us to differentiate between restrictive and the obstructive disorders? What are the tools that can help us to do that? We can divide them into restrictive, where there is restriction to the lung movement, and we have obstructive disorders where there is obstruction to the flow of blood. So there are two major tools which are useful. The first one is the conventional spirometry, and the second one is diffusing capacity of the lung for carbon monoxide, or DLCO. Okay. So now you tell me, in obstructive disorder, what will happen with your forced vital capacity, forced expiratory volume in 1 second, and FEV1 by FVC ratio, and what will happen to DLCO? What will happen to DLCO? Okay. First, we will understand some basics, right? What is this FEV1? What is FEV1? Juhi Bhojani, good. So what is FEV1? FEV1 refers to forced expiratory volume in 1 second. So after a deep maximal inspiration. So please remember starting point here, you take a deep breath. Deep maximal inspiration ke baad, you forcefully exhale. Forcefully exhale. So when you forcefully exhale, you're exhaling, let me say 100 ml. Okay, let us take 1000 ml of gas out. Out of this 1000 ml of gas out, how much is coming out in the first second? That volume is what we call as forced expiratory volume in 1 second. What is forced vital capacity? What is the starting point? Take a deep maximal inspiration, forcefully exhale, और जो total gas अब exhale कर रहे हो forcefully after a deep maximal inspiration, we call it as forced vital capacity. We call it as forced vital capacity. Okay. So now in patients with obstructive lung disorders, what happens to FEV1 and what happens to FPC? So please remember, or let me ask a question rather. जो obstructive lung disorders हैं वो that will affect inspiration more or that will affect expiration more. So please remember, obstructive lung disorders predominantly affect the expiration. Why is it so? Because in obstructive lung disorders, your airway has become little narrow. So the narrow airway is not allowing the flow of air easily. Okay. But please remember that inspiration is an active process. So inspiration basically it is like your lungs are sucking the air from the atmosphere. How are we doing that? We are creating a negative intrathoracic pressure by the diaphragmatic descent and expansion of the chest wall. तो जो volume of the chest है वो increase हो रहा है and that again boils down to boils. If volume increases, pressure inside the chest decreases. Now the pressure inside the chest is lesser than the pressure in the atmospheric air. So because of that, the air is getting sucked into the lung. It's an active process. So even if there is an obstruction, we will be able to overcome it because we are actively taking the air into our lungs. But how do we do expiration? Expiration is a passive process. Means whatever diaphragm that had contracted, it will just recoil back to its position. Lungs which had expanded, they will recoil back. So what is pushing the air out? It is the recoil of the lung tissue. We are not actively contracting the chest wall and diaphragm to push the air out. So when there is obstruction, we will struggle to push the air out because we don't have active process involved. So inspiration will not be affected much. It is the expiration which gets affected. Now, when expiration gets affected, what will happen to the FEV1? Obviously, it will be decreased. Okay. So FEV1 in patients with obstructive lung disorder will be decreased. What will happen to the forced vital capacity? Forced vital capacity, because we are forcefully trying to exhale all the air out. अगर हम we are starting with deep maximal inspiration, जितना अंदर ले रहे हैं उतना बाहर तो we will be able to bring it out. So FVC is generally normal, or if it is decreased, it will be minimally decreased. So when I look at the ratio, what will happen? जो ऊपर का है that has decreased, FEV1 is decreased, FVC is normal. So in that case, what will be the FEV1 by FVC ratio? That will be decreased. So please remember the normal, as we all know, normal FEV1 by FVC ratio is more than 0.7. Simple words, if I have to tell you, take a deep maximal inspiration. So let me say I have taken an inspiration of 1000 ml, right? This is deep maximal inspiration. Just giving you hypothetical example. Now I will be able to expel all this out, right? So whatever I expel out, total volume. So I will be able to expel 1000 ml out. So this 1000 ml is my forced vital capacity. The amount of air exhaled, right, forcefully after deep maximal inspiration. But all of this 1000 ml will not come out right in one go, right? So let me say that 700 ml came in first second. Okay. Then another 250 ml in second, and another 50 ml in the third second. So it took around 3 seconds for me to exhale all the air that I had deeply maximally inhaled. But whatever amount I was able to exhale out in the first second, that becomes my FEV1. So we are looking at the ratio of this FVC and FEV1. Normally, in the first second itself, we will be able to throw out more than 70% of the gas that we have forcefully inhaled. So that is why normal FEV1 by FVC ratio is more than 0.7. But once we have obstruction, the first second effort goes in overcoming the obstruction. So this I will be able to exhale all this air out because I'm doing a forceful expiration, but I will not be able to throw out 700 ml in the first second. So that will drop down to, let me say, 500 ml. So I will do another 300 ml in the second, and then another 150 ml in the third second, and maybe 50 ml in the fourth second. My expiration is now getting prolonged, and I am exhaling out lesser quantity of air in the first second. So FEV1, once I have an obstruction, has decreased. FVC largely remains same. So the ratio will become less than 0.7. So this FVC by FEV1 by FVC ratio less than 0.7 is the hallmark finding of patients with obstructive disorders. Obstructive disorders. Okay. In the restrictive disorders, what happens to the forced vital capacity? Something is restricting the expansion of the lungs, right? Either lung disease like idiopathic pulmonary fibrosis or sarcoidosis or chest wall deformity. They are restricting the expansion. So will I be able to take a forced maximal expiration, inspiration? No. The 1000 ml example I give, that will become 800 ml. So in that case, FVC is decreased. Now if I have taken 800 ml in, I will be able to throw 800 ml out. So FVC will be like FVC is decreased from 1000, it has come down to 800, but I am able to throw that 800 ml out, and out of that 70% or more I will be able to throw out in the first second, because nothing is obstructing here, it is restrictive disorder. So FEV1 here will be normal. FEV1 here will be normal, or if it is decreased, right? If it is decreased, it will be proportionate to decreased FVC. So in that case, when I look at the FEV1 by FVC ratio, what will happen to the ratio? Obviously, it will be more than 0.10. So in a patient with restrictive disorders, FEV1 by FVC ratio will be normal. In a patient with obstructive disorder, it will be decreased. Okay, so now I will tell you one scenario. You should tell me whether we have obstructive disorder or restrictive disorder. So this patient's FVC is normal, FEV1 is normal, and FEV1 by FVC ratio is more than 0.7. So is this obstructive disorder or restrictive disorder? What is it? Obstructive or restrictive? This patient does not have obstruction or restriction because all the parameters are normal. So this is a normal individual. But yahin pe, if I just make a mention that FVC is reduced and this is the outcome, then it will become a restrictive disorder. And instead, if I mention that FVC is normal and FEV1 is reduced and this ratio is less than 0.7, then it will become an obstructive disorder. Clear? Okay. Now, what is the role of DLCO in diagnosis of respiratory disorders? Role of diffusing capacity of lung for carbon monoxide in patients with respiratory disorders. A very, very important one. So DLCO assesses the integrity. What are we looking at? We are looking at the diffusion of carbon monoxide. Now, where the diffusion of the carbon monoxide happens, please remember the airway is divided into the conducting airway and gas exchange airway, right? So just let me put a page here. So airway is divided into the conducting airway and gas exchange airway. Conducting airway is lined by the pseudostratified ciliated columnar epithelium. So it can only conduct the gas. It cannot absorb or exchange the gases, right? So that airway is called as conducting airway. So it includes trachea, from trachea to terminal bronchiole. Terminal bronchiole, because its epithelium does not allow the gas exchange. So it is only a pathway for flow of gas. And then we have the distalmost part of the airway called as gas exchange airway. Gas exchange airway, which includes the respiratory bronchioles, which lead to what we call as alveolar ducts, and they lead to alveolar sac or alveoli. And all this collectively is what we call as an acinus, right? Collectively, it is called as a respiratory acinus. So respiratory bronchiole with its all alveolar duct and with its all alveoli, we call it as respiratory acinus. So gas exchange happens at respiratory acinus. Now DLCO tests the integrity of the conducting airway, or it tests the integrity of the acini. Where is the diffusion or gas exchange happening? Acini. So when there is damage to acini, the DLCO, diffusion of the carbon monoxide will come down, so DLCO will be less, right? So the decreased DLCO indicates that you're dealing with the disorders which are affecting lung parenchyma. Now you may be asking what is the parenchyma. So please remember, when I say parenchyma in respiratory disorders, it refers to the respiratory acini plus the connective tissue that is holding all these acini together. And when you say airway, we are primarily referring to the conducting airway. So if you say that this is an airway disorder, we are talking about conducting airway. If you say that this is a lung parenchymal disorder, so it is a disorder which is affecting the acini, means the respiratory bronchiole, alveolar ducts or alveoli, or the connective tissue. So can I say DLCO assesses the integrity of the parenchyma? Yeah, right. So DLCO will be reduced in parenchymal disorders. Parenchymal disorders. The examples for parenchymal disorders are, first one is the interstitial lung diseases, right? ILDs, idiopathic pulmonary fibrosis, NSIP, sarcoidosis. Then the second one is pneumonia. What is pneumonia? Pneumonia is a disease affecting the alveoli, right? It is a disease affecting the alveoli. ARDS. ARDS is again collection of fluid in the alveoli. So they are all affecting the parenchyma. So they all will cause decrease in the DLCO. Okay. Then what about COPD? COPD, please remember, is a disease of both airway. COPD has two components. One is chronic bronchitis. So we are saying that bronchi are inflamed. And when I say bronchi, we are primarily referring to the conducting airway. Right? So all bronchi from trachea, uske baad mein to bronchi bante hain. So they're all part of the conducting airway. So that is an airway disorder. But then we also have a component called as emphysema. What is emphysema? Irreversible dilatation of alveoli. So we are referring to the parenchymal disorder. So COPD is an airway plus parenchymal disorder. And because of that, airway component is obstructive disorder. But the parenchymal component is a restrictive disorder. And there we can have decrease in the DLCO. So in COPD also, you can have decrease in DLCO. So if you have a pure airway disorder, you can have normal DLCO. And sometimes in patients with asthma, DLCO can be increased. So they can ask you, increased DLCO is seen in what all conditions? So it can be seen in patients with asthma and patients with pulmonary hemorrhage. So if there is through those injured blood vessels, the carbon monoxide will be diffusing into the blood. So when you have pulmonary hemorrhage and asthma, you can have increased DLCO. These are also important MCQ points. Okay. So now interstitial lung diseases is a common term which refers to diffuse parenchymal disorder, ILDs. Okay. So this question is primarily talking about ILDs. Why is it talking about ILDs? Because first point I get from the question is that there is decreased DLCO. So that tells me that we are dealing with parenchymal disorder. We're dealing with parenchymal disorder. Can I call it as COPD? I don't have any other pointers to think of COPD or the emphysema, because if it is emphysema, they would have mentioned that patient has got barrel-shaped chest, or they would have mentioned that patient has pursed lip breathing. Other pointers will be there in the question. So COPD nahi hai. So the second thing that should come to my mind is the interstitial lung disease. This can't be pneumonia. If it is pneumonia, then they would have mentioned that the patient has got fever, he has productive cough, and they would have mentioned that there are bronchial breath sounds. That is not the case. So I'm thinking that mostly we are dealing with the case of interstitial lung disease, right? So few words about interstitial lung disease. Interstitial lung disease is classified into two broad groups. The first one is ILDs of known cause and ILDs of unknown cause. ILDs of known cause. The interstitial lung disease is nothing but diffuse parenchymal lung disorders. Disorders which are affecting the parenchyma, that is alveoli or the acini and the connective tissue, right? If the cause is known, we call it as ILDs of known cause. And if the cause is not known, then we will call it as ILDs of unknown cause. Unknown cause. Now, what can come under the ILDs of known cause? Can you give me an example for ILDs of known cause? So the first example you should always quote is sarcoidosis. So in the sarcoidosis, what is the most commonly affected organ? It is the lung. What happens to the lungs? Starting with the hilar lymph node, we form the non-caseating granulomas in the hilar lymph nodes. Uske baad mein we'll start seeing the hilar lymph nodes in the lung parenchyma. So when I say parenchyma, we are referring to the parenchymal disorders, that is like in a chronic form, it is ILD. So sarcoidosis is one of the ILDs of known cause. Okay. Then second one, lot of connective tissue disorders can also cause interstitial lung diseases. So we call them as CTD-related ILDs, connective tissue disorder related ILDs. So under this, what all diseases are known to cause the interstitial lung disease? All diseases that you study under rheumatology, that is rheumatoid arthritis, SLE, okay, then scleroderma, mixed connective tissue disorder. So these are all known to cause ILDs. यहाँ पे cause known है, right? Rheumatoid arthritis has led to ILD or SLE has led to ILD. So that is ILDs of known cause. Now, when ILD is of unknown cause, obviously we don't know the cause. We will call it as idiopathic. You have to remember two important ones. The first one is, I forgot to mention one more thing. In PSM, you study about pneumoconiosis. Right? What is it? Disorders affecting the lung parenchyma because of exposure to some substances at patient's workplace. They are also ILDs only. So all the pneumoconiosis like asbestosis, silicosis, they are all interstitial lung diseases. Causes directly known: asbestos exposure, silica exposure, beryllium exposure, coal exposure. So they are ILDs of known cause. The first one is called as idiopathic pulmonary fibrosis. I think someone had already diagnosed it as possible IPF. Okay, idiopathic pulmonary fibrosis. The second one is idiopathic non-specific interstitial pneumonia or NSIP. Now, apart from this, I also want you to remember a small table of important causes which are usually discussed under ILDs of unknown cause, but I'm putting a separate table. We call them as smoking related ILDs. Smoking related ILD. So there are some idiopathic ILDs, though we don't have the proof to say that smoking is the direct reason. That's why otherwise we would have called it as smoking induced ILDs. We call it as smoking related because they are typically seen only in smokers and not usually encountered in non-smokers. So what are those? You have to remember this because they ask this MCQ. Which of the following is known as a smoking related ILD? So first one is there is an ILD called as desquamative interstitial pneumonia or DIP. Desquamative interstitial pneumonia or pneumonitis, also called as DIP. The second one is respiratory bronchiolitis associated ILD or RB-ILD, and the third one is pulmonary Langerhans cell histiocytosis. These are considered as smoking related ILDs. इसका मतलब ये नहीं है कि the other ILDs have nothing to do with smoking. Smoking is a risk factor for several ILDs, but these ILDs, which are called as smoking related ILDs, are almost exclusively seen in smokers. I don't smoke, so I don't run the risk of developing these. Okay. If I smoke, I do run the risk of developing other ILDs as well as this. But by not smoking, right, I will significantly reduce the risk of these smoking related ILDs. Okay. Now, how do I differentiate between these different ILDs from the question? First thing is, how do I recognize that this is an ILD? So the pointers towards ILD is first one, they would mention the PFT pattern, right? So in the question, I have to identify it is an ILD or not. So pointers to diagnosis of ILD. First pointer will be the PFT. So in the PFT, because ILD is a restrictive lung disorder, so in the PFT you will have forced vital capacity reduced, FEV1 fairly normal, and thus you will have FEV1 by FVC ratio more than 0.7. That is one pointer. The second pointer that you can get from the question is because it is a parenchymal lung disorder, the DLCO will be reduced. Third, because it is the alveoli or acini that is being affected, right? Their movement can produce kind of fluttering sound. That is what we call as the fine crackles. Fine crackles or crepitations. So when these parameters are mentioned in a question, the thing that should come to your mind is that you're dealing with the interstitial lung disease. Okay. Now, the last point is how do I see whether this patient is ILD because of sarcoidosis or CTD related or IPF or idiopathic NSI. So radiology holds some clues. What is the radiology clue? The radiologist, when you send the patient with ILD, they will not directly tell you this is sarcoidosis or this is IPF. They will tell you what they find. So they will report their findings in two headings. One is one appearance, they call it as UIP pattern. UIP pattern. And the other appearance, they call it as NSIP pattern. So what is the characteristic that they see in the UIP pattern? In the UIP pattern, there is so much of fibrosis that the fibrosis has resulted in pulling of the bronchi in different direction. And when they pull the bronchi in different direction, what will happen to the bronchi? They are getting stretched. When the bronchi get stretched, what do we call it as? We call it as bronchiectasis. Why are they getting stretched? Because of the traction. So we call it as traction bronchiectasis. So in UIP pattern, we will see traction bronchiectasis. Traction bronchiectasis. And the second, if too many of the bronchi become bronchiectatic, then the whole lung field starts looking like honeycomb. It will start looking like honeycomb changes, right? We call it as honeycomb changes. And what do I get in the NSIP pattern? In the NSIP pattern, the alveoli are filled with the substances, making it look like full, and that kind of gives the appearance of what is called as ground glass opacities. So the usual most important finding here will be ground glass opacities. Ground glass opacities or GGOs. So what are these GGOs? These are semi-translucent opacities, neither fully opaque, full white, nor full like normal looking dark, somewhere in between. We call it as ground glass opacities. So in what condition we get UIP pattern? UIP pattern we typically get in patients with IPF, and NSIP pattern we get in patients with idiopathic NSIP, then in patients with sarcoidosis, and almost, I wouldn't say all, sarcoidosis and connective tissue disorder related ILDs. Connective tissue disorder related ILDs. What we understand so far is that patients with the UIP pattern or IPF, right, they carry poor prognosis. Poor prognosis. And the patients with the ground glass opacities and having an ILD, they carry better prognosis. They carry better prognosis. So now just quickly get back to the question that we were talking about. So in this question, what I understand, this is a chronic disorder. She has non-productive cough. She has a history of connective tissue disease. They have not mentioned which one, but she has a history, right? On examination, she has digital clubbing and bibasilar fine inspiratory crackles. HRCT shows bilateral ground glass opacities and reticular changes, honeycombing in lower lobes. Okay, so all of this pattern is more in favor of. I know that you are seeing there are ground glass opacities, but honeycomb changes also. The honeycomb changes favors the UIP more. That means there is more severe fibrosis. So we are dealing with UIP pattern. UIP pattern. And UIP pattern is typically seen in idiopathic pulmonary fibrosis. But there is a catch here. In the history, they have mentioned that patient has got the connective tissue disease. So now what should I take it as? Because in connective tissue disorder, sir told that NSIP pattern is usually what we see. But please remember, some connective tissue disorders can have the UIP pattern. So what are those CTDs where ILD can be of UIP pattern? CTDs with ILD of UIP pattern. CTDs with ILDs of UIP pattern includes rheumatoid arthritis. Most of the times when you have rheumatoid arthritis and develop the ILD, it will be UIP pattern. That's a very bad case scenario. Second thing is scleroderma. Okay, again, please remember scleroderma has two types, the limited cutaneous and diffuse cutaneous, right? Limited cutaneous and diffuse cutaneous. Most patients with diffuse cutaneous end up developing like the NSIP pattern, but some patients can develop the UIP pattern, right? Some patients with diffuse cutaneous variant. Diffuse cutaneous variant. Now that this patient has the backdrop of connective tissue disorders and she has developed a UIP pattern, UIP pattern always need not rule out the CTD-related ILDs and make that it has to be a case of IPF. No, that's not the rule. Most cases of UIP pattern are because of IPF, but not all. So I'm still taking this diagnosis to connective tissue disorder associated interstitial lung disease. Okay, that is a possibility. And there are few points in this question which are going against the diagnosis of IPF. So I want you to intelligently answer what are the points which are going against the diagnosis of IPF. What points do not favor the diagnosis of IPF here? So few points about IPF and idiopathic NSIP also before we move to the next topic. Idiopathic pulmonary fibrosis, right? As the name says, it is idiopathic. So obviously we don't know the exact cause, but we know certain risk factors. And this is what I want you to remember here. When we talk about the risk factors for the idiopathic pulmonary fibrosis, first thing is most of the patients of IPF are elderly. So age more than 55 or 60 years is an important risk factor. Second, more than two-thirds of the patients diagnosed with IPF have significant history of smoking. Smoking is an important risk factor. And the third one is the gender. And when it comes to gender, it is the males. Obviously, males smoke. Makes sense, right? Genetics also plays a role, not important as of now. So these three are important risk factors. Elderly, male who smokes. Clear? Okay. And another pointer that you have to remember in patients with IPF is that clinical features wise, yes, they will present with chronic cough and shortness of breath. Importantly, the examination reveals the fine end inspiratory crackles, which are usually described because they're fine crackles, they're usually described as Velcro crackles. Usually described as Velcro. Why I'm stressing it? Because that is an examiner's clue. Examiner is telling you that consider the diagnosis as IPF if I'm telling you that patient has got Velcro crackles. They're called as Velcro crackles. Okay. So diagnosis, I think you will get the UIP pattern on the HRCT. So for all ILDs, the investigation of choice is going to be HRCT, and on HRCT we get UIP pattern. So an elderly male who has smoked chronically now presents with shortness of breath and cough, and I do an HRCT or do a PFT, I get restrictive pattern. I do an HRCT and I get the UIP pattern. Then I make a diagnosis of idiopathic pulmonary fibrosis. In a female, first I would not be jumping to the idiopathic pulmonary fibrosis. I would be thinking of NSIP or connective tissue disorder related. And here that clearly history mentions that patient has connective tissue disorder. I'm going ahead with the diagnosis of CTD-related ILD. Okay. Few points about it before we move. How do I manage these patients? So when it comes to management of the idiopathic pulmonary fibrosis, the first line management, we have certain anti-fibrotic drugs, anti-fibrotic agents. So these agents include drugs like nintedanib and pirfenidone. So these are the anti-fibrotic agents. We use them as first line agent. And second line agent, we can use immunosuppressants like azathioprine, mycophenolate mofetil, tacrolimus. We can use, including steroids. We can use immunosuppressants. In more severe cases, we also use cyclophosphamide. If immunosuppressants are not working as a third line treatment, we don't have choice of drugs, so we go for the lung transplantation. Lung transplantation. So we have one more idiopathic ILD, that is ILD of unknown cause, that is idiopathic NSIP. Idiopathic NSIP. Very easy to remember what is idiopathic NSIP. All you have to remember is remember IPF risk factors and think everything opposite to it. That's it. Your NSIP is. So what is NSIP? So NSIP is idiopathic non-specific interstitial pneumonitis. Its risk factors are exactly opposite of the risk factors for the IPF. So this is typically more common in young individuals, usually less than 50 years. Second, it is more common in non-smokers. And third, it is more common in females. So exactly opposite of IPF, right? So If you are a young female who do not smoke, you are at the risk of developing non-specific interstitial pneumonitis. Like if you are an elderly male who has already smoked, you are at the risk of developing idiopathic pulmonary fibrosis. Okay. So in these patients, what HRCT is going to show in the NSIP patients, HRCT will show NSIP pattern, which is characterized by ground glass opacities. And how do I manage these patients? I have already told you, getting NSIP pattern on the HRCT is a good news for a treating doctor because prognosis is good. Getting UIP pattern means bad prognosis. So in these patients, generally they respond well, and the drug of choice is usually steroids plus or minus immunosuppressants. Immunosuppressants. These patients generally do not require the lung transplantation. They respond well to steroids. If not, they respond to immunosuppressants. Okay. So we are going ahead with the diagnosis of connective tissue and not idiopathic pulmonary fibrosis because the age fair, but the gender goes against, and there is also no mention of the smoking history, and there is a clear history pointing towards the connective tissue disorder in the patient. Okay. So that covers the quick points about the ILD. We will go to the next question. So here we have a 60-year-old male who is a smoker, presents with chronic cough, dyspnea on exertion, and frequent exacerbations. His COPD assessment score or the CAT score is 25. Which of the following treatment is most appropriate initial treatment? So basically, this question is about COPD, right? COPD is again an important template for the exams. So what is the basis for us to decide what should be the initial treatment? For COPD, for diagnosis as well as management, we follow what is called as GOLD guidelines, right? So currently we are in 2024 and we have 2024 GOLD guidelines. So according to that, how do we manage a case of COPD? Based on the GOLD guidelines. Okay, so few points about COPD. First thing is, as I have already told you, COPD is a disease of airway as well as the parenchyma. So this is the disease of airway and parenchyma. Now, what is causing to what is it causing to the airway? It is causing chronic bronchitis. Chronic bronchitis, and chronic bronchitis is an obstructive lung disorder. It is an obstructive lung disorder. And what is it going to cause to the parenchyma? It is causing irreversible dilatation of the alveoli or the respiratory acini. So what do we call it as? Emphysema. We call it as emphysema, which is a restrictive disorder. It is a restrictive disorder. So COPD in itself is both obstructive as well as restrictive disorder. It is a disorder of airway as well as parenchyma. Okay. Now, what are the risk factors for COPD? The most important risk factor is obviously smoking. Smoking, and studies have shown that when someone smokes more than 15 pack years, the risk of COPD significantly increases, right? Then second, COPD also happens in non-smoker. That itself is an MCQ. What is the most common cause for COPD in non-smoking females? Smoking is the most common cause, obviously. This is the most common cause. But right, the most common cause for COPD in non-smoking females is burning of chula, biomass fuel, because they use this cow dung patties or the wood logs for cooking, right? So that smoke becomes the reason. So burning biomass fuel. Okay. Other than that, genetics is also an important risk factor. And when we talk about genetics, please remember it is the alpha-1 antitrypsin deficiency, which is an important risk factor for someone to develop COPD. Alpha-1 antitrypsin deficiency affects two organs. What are those? Liver and lungs. And because COPD has two subcomponents, chronic bronchitis and emphysema, what alpha-1 antitrypsin deficiency predominantly causes? It predominantly causes emphysema. It predominantly causes emphysema. Okay, that obviously begs one more question, because smoking also causes emphysema. Alpha-1 antitrypsin deficiency also causes emphysema. Can I detect whether this particular patient has alpha-1 antitrypsin deficiency or whether it is because of smoking without checking the alpha-1 antitrypsin levels then? Well, that is possible because the lobes affected by smoking and the lobes affected by alpha-1 antitrypsin deficiency are different. So in smoking, right? Smoking induced emphysema. This predominantly affects the upper lobes. Predominantly affects the upper lobes. And alpha-1 antitrypsin deficiency associated emphysema. Associated emphysema predominantly affects the lower lobes. Lower lobes. Okay. How to remember it? That is pretty simple. So when you start smoking, you tend to feel high. So think of upper lobes. Smoking, you feel high, upper lobes affected. You are declared that you have a genetic disease like alpha-1 antitrypsin deficiency. You feel low. So think of lower lobes being affected. Okay, so that is about the risk factors for COPD. First MCQ point is how many back years are required for development of COPD? Generally 15. 30 plus increase the risk of developing lung cancer. Most common cause is smoking. In non-smoking females, it is not passive smoking. Don't make that mistake of answering passive smoking. Passive smoking also increases the risk, but that's not the leading cause. We see plenty of females in our government hospitals presenting with COPD. They are not because they have been exposed, their husbands were smoking or their kids were smoking. It is because they were cooking the food using the biomass fuel. Okay. Now, what clinical features I should expect in a patient with COPD? First thing is, in a patient with COPD, you should remember that you have two components. One is chronic bronchitis. Patients with chronic bronchitis are often addressed as blue bloaters. They're called as blue bloaters because generally, because of airway obstruction, there is reduced oxygenation of the alveoli and thus they have cyanosis. They have cyanosis. And one more MCQ that they ask you is, what is the definition for the chronic bronchitis? How do you define chronic bronchitis? So please remember the definition of chronic bronchitis is a clinical definition. You don't need to do a biopsy of the bronchi to prove that there is inflammation. It's a clinical definition. What does it say? Cough, which is productive. Productive means cough with sputum production. Productive cough of more than or equal to 3 months duration per year. Every year, patient should have a cough with sputum production for at least 3 months for two consequent years. For 2 consecutive years. That is the definition of chronic bronchitis. This is very important because very often they twist the numbers here. Whenever there are two numbers coming into one statement, they twist. It's like cough of 2 months for 3 consecutive years. That is where we can get confused. Okay. Then we have a second component of the COPD, that is emphysema. Emphysema is a pathological definition, not a clinical definition. Emphysema is defined as irreversible dilatation of, more precise word is acini, but traditionally most of the books mention alveoli. So fair enough, but it is the acini. It's not just the alveoli, but even the respiratory bronchiole or the alveolar ducts may be dilated. That's why even emphysema is further classified as panacinar, paraseptal, right? Okay. Or the centri-acinar, centrilobular. So emphysema is irreversible dilatation of acini. Okay. Now emphysema, when acini are getting dilated, why are they getting dilated? The main reason is the obstructive disorders predominantly affect the expiration. So what happens? The air comes into the alveoli during inspiration reasonably comfortably, but now this air is not able to go out. So air goes on coming into the alveoli. This has difficulty to go out. So alveoli start dilating. As they start dilating, their wall starts getting destroyed. So we end up in a state where this dilated alveoli is not recoverable. It is irreversible. Then we call it as emphysema. Now what happened? All that air that came into the alveoli is trapped into the alveoli. It is not going out. So what will happen then? The residual volume, the volume of air in the lungs, staying in the lungs increases. Residual volume increases. So because of that, what will happen to the size of the lung? Size of the lung is increasing. So the increasing size of the lung cannot make you go wider, because rib cage is fixed anteriorly and posteriorly to the spine and the sternum. It can only expand antero-posteriorly, not horizontally. So now we start seeing that their chest starts bulging antero-posteriorly, changing the normal appearance of flat chest to a barrel-shaped chest. So patients with emphysema often develop barrel-shaped chest. Barrel-shaped chest. Now think of these patients. These patients have one side obstruction because of chronic bronchitis. Second side, the alveoli are all dilated. So diaphragm is getting pushed down and down. Now these patients have difficulty to exhale the air, right? Obstruction plus dilated lungs makes it very difficult for them to exhale the air. So they make some adaptive changes in their posture to exhale the air easily. What are those adaptive changes? First thing, they start pursing the lip to breathe. So we see these patients developing pursed lip breathing, pursed lip breathing. The second thing we will see in these patients is that they tend to sit, bend forward, rest their elbows on the thigh and sit. We call that position as tripod position. Tripod position. So we will see all these changes in a patient with emphysema. Okay. And in a more severe form of emphysema, the lower part of the chest may not move out during inspiration. We call that finding as Hoover's sign. All these can be potential image-based questions. So please go through the notes for the images of these signs that are mentioned, because there is a potential that they might ask one of these as image-based question. Okay. Now, when I get a patient, right, with all these findings, how will I make the diagnosis? For a diagnosis of COPD, well, I would suspect it based on the fact that patient has smoked significantly, but I have to establish a PFT and X-ray based diagnosis. PFT will help me to confirm that there is obstruction. So what will PFT show? It will show FEV1 by FVC ratio less than 0.7. But ये तो asthma में भी हो सकता है, right? So please remember one point here, the COPD, the obstruction that we see here is persistent obstruction. It is persistent obstruction. Means the obstruction is not completely relievable. In asthma, whenever it is triggered by allergen, it goes into constriction, but otherwise it is relievable when you give bronchodilators or खुद relief हो सकता है. So now I have to prove that this obstruction that I'm seeing here, see, this only indicates that there is obstruction. I have to prove that this is persistent obstruction. How do I prove? I give a bronchodilator nebulization and I will see what happens to the FEV1. If obstruction is relieved, FEV1 will improve. If obstruction is not relieved, FEV1 will not improve. So after this, we do what is called as bronchodilator reversibility test or BDR test. So what we do in BDR test? In BDR test, we give the patient a short acting beta agonist. So abhi pehle hi for FEV1 by FVC ratio, we have got the FEV1 check, right? So that is our baseline FEV1. So we know the baseline FEV1 kitna hai patient ka. Baseline FEV1. And then after that, we will administer a short acting beta agonist, SABA. And then we will recheck the FEV1. Recheck patient's FEV1. How much improvement we are seeing. So if more than 12% increase in the FEV1, that means it is reversible obstruction, right? So in that case, if the obstruction is reversible, then it is a case of asthma. But if I have less than 12% improvement or no improvement at all, so if there is less than 12% rise, in that case, we are dealing with irreversible obstruction, And in that case, it becomes a case of COPD, right? It becomes a case of COPD. So in COPD, bronchodilator test will reveal that there is less than 12% improvement in patients FEV1 after administration of short-acting beta agonist like. Okay. Another thing that can help us to diagnose the COPD is DLCO, because DLCO will be decreased because emphysema is a parenchymal disorder and gas exchange happens at the acini which are part of parenchyma. So DLCO will be decreased. Okay. Now emphysema can better be documented by the chest X-ray. Now what findings I will get in chest X-ray, because more and more air is getting trapped in the lungs. Lungs are expanding. That is pushing the diaphragm down. So we will be often seeing these patients having flattened diaphragm. Flattened diaphragm. I think I probably might have an image of it. So let me see if I have a image that can be useful for you. Just give me a second. I will show you an image of COPD chest X-ray also. So you can clearly see here, one chest X-ray is normal, the other one is with emphysema. So this patient with a normal chest X-ray, you can see that the diaphragm looks like a dome, right? Normally diaphragm looks like a dome. But once the lungs are expanding, the diaphragm gets pushed downwards and they become more flattened. So in the second image, you can see that the dome is lost and they kind of look flattened. That is first finding. Second, the expanding lungs will also make less space available in the mediastinum, making the heart look like a tube. That is what we call as tubular heart. So this is how the normal cardiac silhouette looks like. Here it is kind of looking like a tube. So we call it as tubular heart. So these are the two important findings that you need to remember for recognition of emphysema on the chest X-ray. Flattened diaphragm, and the second one, tubular heart. Tubular heart. Okay, so once I have done the diagnosis of COPD, my next question is, how do I manage it? So for management, as I've already told you, we follow the GOLD guidelines. Okay, so what GOLD guidelines recommend is, for any patient with COPD, we start them with nebulization. The inhalers, meter dose inhalers. Now, what I have to decide is, should I start a combination inhaler or a single drug inhaler? That is the only decision. That is the initial step. Okay, बाद में we can go on escalating. I might have started with single drug, not working. I can go to combination. But how do I decide whom should I give a single drug inhaler and whom should I give the combination? So before that, let me tell you what inhalers we can use. So what inhalers we can use? We can use long-acting anti-muscarinic agents and long-acting beta agonists. Okay, how long-acting beta agonist will be helpful? Though COPD, the obstruction is persistent, some amount of dilatation is possible. That's why we said, right, up to 12% improvement in FEV1 is possible. More than 12%, it means it is reversible. So we will call it as asthma. So we want to tap that benefit, right? That 10%, 8% improvement that we can achieve by bronchodilators, we want to achieve that. So we can give beta agonist. Okay. Now, when it comes to bronchial muscle tone, right, the sympathetic nervous system causes bronchodilation and parasympathetic causes bronchoconstriction. So what we want to do, either we have to give sympathomimetics to cause bronchodilation or we have to block the parasympathetic. So long-acting beta agonists are sympathomimetics, right? Beta receptor stimulators, so they are causing bronchodilation. Or another choice I have is I can block the parasympathetic nervous system, and the receptors that we see, the acetylcholine receptors that we see in the bronchial smooth muscles are muscarinic receptors. So we need the muscarinic receptor blockers or LAMA. Now LAMA has an added advantage because the anti-muscarinic agents reduce the secretions. And in chronic bronchitis, we just studied that there is increased production of secretion. That is why they have cough with sputum. So by reducing secretions, it can make the patient's symptoms better, and also the secretions become a breeding ground for bacteria. So bacteria grow in their secretion, cause pneumonia, worsen the COPD. So by reducing secretions, I can reduce the risk of infection and COPD worsening. So that is why LAMA has an advantage. Now the question is, should I start LABA or LAMA or both, right? How do we make that decision? That decision takes into account two things: how badly the COPD is getting exacerbated and how severe is patient's shortness of breath. The dyspnea severity and exacerbation. Two parameters are taken into account. So how do we approach this question is, from the question, try to get the information about two, three parameters. What are those? First thing is, I will write down a question, right? You have to find answer for this question in any given MCQ, right? Whether the answer is yes or no. That's all you have to decide. So what is that? Did patient have more than or equal to 2 moderate exacerbations? Moderate exacerbations in the past 1 year, or more than or equal to 1 severe. And when I say severe, it refers to exacerbation requiring admission, severe exacerbation. the exacerbation requiring hospitalization. Hospitalization in last 1 year. In the past 1 year. Okay, this is the question that you have to find the answer in the MCQ's history or patient's history. Now this answer may be yes or no. So what is this moderate exacerbation? Exacerbation or worsening of the symptoms requiring medical attention. Symptoms requiring admission is severe exacerbation. Symptoms slightly getting worse but did not require medical attention, patient managed on their own, that is mild exacerbation. So we have to find the answer for this question, right? The question ke liye answer may be yes, or you may say, sir, patient did not have any major exacerbations in the last 1 year, neither minor nor majors. In that case, the answer will be no. So if the answer for this question is yes, we will put the patient in category E of the COPD. We will put the patient in category E of the COPD. And if the answer to these questions is no, then we have two categories to decide, either category A or category B. See, this is pretty simple. When you read these questions, right, whatever I have written here, what are they pointing towards? They are mainly pointing towards the exacerbation history. Kya patient ko exacerbation is bothering him badly. If answer is yes, then patient will go into an exacerbation predominant category. That is what it's called as category E. Okay. If you say no, then exacerbation is not a major concern. But still patients can have shortness of breath as a major concern. So we have to now look at the Modified Medical Research Council grade or COPD assessment tool or CAT score or CAT score. This tool will help us to understand the severity of shortness of breath in a patient with COPD. Okay. Now, what is the possibility? If you're following MMRC grade, it could be grade, there are 0 to 4 grades. So it could be grade 0 to 1 MMRC, or if you're following the CAT score less than 10. And if you're following MMRC, the grade more than or equal to 2 MMRC grade, or if you're following the CAT score more than or equal to. So if the CAT score is less than 10 or MMRC grade is 0 to 1, we will put the patient in category A. And if the CAT score is more than or equal to 10 or the MMRC grade is 2 or more than 2, then we will put the patient in category B. Now, how do we manage these patients? See, look at the category A patient. How did I reach the category A? First, exacerbation was not a major concern. Severity of dyspnea is also on the milder side. So this is the milder end of the COPD. For these patients, right, treatment will be any bronchodilator. So either give them a LABA or give them a LAMA. Either a LABA or a LAMA. But what about the category B patients? In them, though exacerbation is not a big concern, shortness of breath is a big concern. So how do we treat them? We will treat them with two drugs, LABA plus LAMA. And what about these category E patients? These patients definitely require two drugs. So we will treat them with LAMA plus LABA. That is going to be our approach. So simple words, B and E, we treat them with the LAMA plus LABA. For category A, we give any bronchodilator, anyone, either LAMA or LABA. We don't have to give combination. Simple, clear? So now let us get back to this question and see if we can get it right now. So his CAT score is 25, right? Which of the following treatment is most appropriate initial therapy? So in the history, they have not mentioned anything related to exacerbation. So let us presume that there is no significant moderate or mild exacerbation. So for this question, what is the resultant answer? I'm going ahead with no. This patient does not have significant exacerbation. Agar hota, to they would have mentioned in the question, saying that in the last 1 year he was hospitalized once, or he had to go to doctor many times for change in the treatment. That is not mentioned. So exacerbation is not significant. So the answer is no. Now what should be my next step? Either look at the MMRC grade or CAT score. CAT score more than or equal to 10 or MMRC grade 2 or more than 2 should mean that it is category B, right? Agar CAT score less than 10 hai ya MMRC grade 0 to 1, then it will be category A. So from this story, what category this patient should belong to? Presumption is that there is no exacerbation. We are deriving it based on the story in the question, right? Presumption, no exacerbation because it is not mentioned. Okay. Then CAT score is 25, that is more than 10. So which category this patient belongs to? This patient belongs to category B, right? So this is a case of category B COPD, right? And how do we treat category B and E? Category B and E are treated with combination of LAMA plus LABA, LAMA plus LABA. So what should be the right answer here? Do we have the right answer in this question according to the current guidelines? See, the question appeared in one of the previous NEET PG exams, but guidelines over time have changed. So what should be the right answer according to the current guidelines? Can it be oral corticosteroids? Corticosteroids do not have a direct role in patients with COPD. Whatever patients in your OPD or inpatient they are getting steroids, they are not getting it based on the guidelines. Okay. Theophylline, all of you know, has a very narrow therapeutic window, so we don't use it in routine practice today, right? So if you ask me to choose one, right, I would definitely choose tiotropium here because again, steroids have limited role in a patient with the COPD. So fluticasone is a steroid. Salmeterol is a beta agonist. Right? So I would choose B. But if more precisely you ask me, then I would rather choose a combination of salmeterol plus tiotropium. Tiotropium. This combination would be the right answer for this question with current guidelines in mind. Back then, when this question was asked, well, guidelines were suggesting LAMA or LABA in cases of category B. So back then we could have chosen tiotropium as the answer. Now also, if I have to press and ask me to pick one, then I will still choose tiotropium. But otherwise, ideal answer in today's context will be a combination of LAMA plus LABA. Okay. Now, the one last thing that they will ask you about COPD is all these treatments, right? They make their symptoms better. They don't reduce the mortality. They don't reduce the mortality. So there are a few points that they will ask about COPD and mortality. COPD and mortality. First question they will ask you is what is the most common cause for death in patients with COPD? Most common cause for death in patients with COPD. All of you may be thinking that it is the cor pulmonale or it is the heart failure. No, it is the coronary artery disease. Most of the COPD patients die out of heart failure not because of hypoxia or hypercarbia, right? Because COPD is an inflammatory condition that increases the rate of development of atherosclerosis. So they will develop ischemic heart disease much earlier than their non-COPD counterparts and they die out of it. That is the most common cause of death. Then the treatment that reduces COPD mortality, reduces COPD mortality. The treatment that reduces the COPD mortality is there is some link to the inflammatory markers in patients with COPD and the persistence of hypoxia. See, hypoxia will increase inflammatory markers. Inflammatory markers will cause pulmonary vasoconstriction. Pulmonary vasoconstriction will result in resistance to the flow of blood through pulmonary vasculature. So right ventricle does more work, develop right ventricular hypertrophy. Hypertrophic right ventricle will require more blood supply. Nahi milega, that is ischemic heart disease, patient will die. So we can cut this route by keeping the patient's oxygen levels reasonably. So the only treatment that actually reduces COPD mortality is the long-term oxygen therapy. Long-term oxygen therapy or LTOT, right? So that's about the COPD. So please remember this categorization because that is something that they repeatedly ask. What they ask you, they give a story and then they will try to ask you to pick up the right combination. So combination kya hoga? Ek category word and then the combination treatment. Like category E, LAMA alone. Category B, LAMA plus LABA. Category A, LAMA plus LABA. That's how they usually talk about. One more point. Steroids in COPD. Right. Oral and all, there is no direct role, but we can consider LAMA plus LABA plus inhaled corticosteroid if COPD patient is associated with increased eosinophil count more than 300 per cubic millimeter. This basically suggests that if your eosinophil count is slightly on the higher side, In addition to COPD, you may be also having a component of asthma. So this asthma component may not be responding well to agonist alone. You need steroids. So we are adding it only when a COPD patient has high eosinophil count. Otherwise, no role of inhaled steroids also. Okay. Now here is our next question. Which of the following biological can be used for both type 2 and non-type 2 asthma patients? Makwana, Priyanshi, Vijay, absolutely right. Okay. So now which of the following biological can be used for treatment of type 2 and non-type 2 asthma? So we'll just spend 5 minutes on asthma. Just a quick recap. Okay. So what is asthma? Asthma is an airway disorder. COPD is an airway plus parenchymal disorder. Asthma is just an airway disorder. It is not affecting your alveoli. It's an airway disorder which is characterized by obstruction, obviously characterized by, but reversible obstruction. That is the main difference. By reversible obstruction. Okay, so usually when exposed to allergens or noxious gas particles, the airway goes into constriction and causes obstruction. When relieved, it will be back to normal diameter. Okay. Now, asthma, there are several risk factors and all. I'm not getting into the details. I will only focus on what is important from the MCQ perspective. So, there are several ways of classifying the asthma, and most important or currently accepted classification is a form of classification called as phenotypic classification, where we classify the asthma into two types. We call them as type 2 asthma and non-type 2 asthma. The basis for this classification into type 2 and non-type 2 is which helper T cell is involved in the pathogenesis. So the basis for this classification is the helper T cell involved in the pathogenesis. Helper T cell involved in the pathogenesis. So if it is the Th2 cell, right, we will call it as type 2 asthma. If it is Th17 and Th1 cells, we will call it as non-type 2 asthma. Now, why understanding this classification is important? Because this Th2, right, it is a helper T cell. Will it cause directly damage to the airway mucosa and the musculature and cause vasoconstriction? No, right? It will induce some chemicals which will finally bring the cells which are supposed to cause the damage. This is like a messenger, right? You can think like, imagine hum Kargil pe khade hain, we are on the top of the Kargil, right? So there is someone who is observing and they will notice that, okay, the enemy is trying to encroach. So he will send the signals down to the army base camp saying that enemy is encroaching, and then the soldiers will go and fight. So helper T cells are primarily doing that messenger's job, right? So they will send some signals. We will call them as cytokines. What cytokines are sent by the helper T cells? It is mainly the interleukin 4 and interleukin 5. Interleukin 4 and interleukin 5. And these interleukins recruit the final cells, the soldiers who will now fight the battle. So those cells will be called as effector cells. Effector cells. So what effector cells are recruited by interleukin 4 and 5? It is mainly the eosinophils. Eosinophils. Okay. In case of the non-type 2 asthma, these Th17 and Th1 cells are getting activated. So they will result in release of interleukin 1, interleukin 6, and interleukin 17. So they will recruit. So they, instead of going to the land army, it is like telling the maybe Navy or maybe the Air Force. So they are recruiting neutrophils here. They are recruiting neutrophils. Now, eosinophils are going to cause the tissue damage, cause bronchoconstriction. Neutrophils are going to cause the airway damage. They are going to cause the bronchoconstriction. Both will result in asthma, but underlying pathology is different. And in signaling from cytokines to eosinophils, there are some more molecules involved that includes immunoglobulin E, IgE. So these are the three important signaling molecules that activate the eosinophils and cause type 2 asthma. It is the interleukin 1, 6, and 17 which activate neutrophils and cause the non-type 2 asthma. Okay, why this classification is important? Because for all asthma patients, we start the treatment with simple inhalers, but if it does not work, one of the options we have is newer generation of monoclonal antibodies or MABs, right? The MABs inhibit these cytokines. So we should know which type of asthma we are dealing. So if I take a drug which blocks interleukin 4, will it be useful for the non-type 2 asthma? Absolutely no, right? It is money down the drain. And all these monoclonal antibodies are damn expensive, costing 10-15,000 per month. If it is not helping, then it is waste, right? So that is why whenever we make a diagnosis of asthma, we should recognize whether it is type 2 or non-type 2 asthma. How do we recognize whether it is type 2 or non-type 2 asthma? I cannot get into the patient's airway and see whether there is Th2 cell or Th17 cell, but we can get the markers of it, right? So what we do is we look for the biomarkers. Should I do the biomarkers for both type 2 and non-type 2 or only one? We do only one, that is type 2. If type 2 markers are positive, then it is type 2. If type 2 markers are negative, then it is non-type 2. So we should remember what are the biomarkers of type 2 asthma. So what all can be the biomarkers? First biomarker is going to be serum IgE levels. Serum IgE levels will be increased if you have type 2 asthma because it is being induced. Okay, we can also check interleukin 4 or interleukin 5 levels, but they are very expensive. We have some simple alternatives. What is the simple alternative? There is something called as fractional exhalation of nitric oxide. So when we exhale air, right, we are inhaling some amount of nitric oxide, we exhale it back. But if I add more nitric oxide while exhaling, that means that nitric oxide is coming from the tissues or the airway. What is producing the nitric oxide? Usually, the tissues under attack by eosinophils produce nitric oxide. So if I am exhaling more nitric oxide than I am inhaling, it is telling me that my airway is producing nitric oxide. It means that it is under the eosinophilic attack. So indirectly it tells that I have type 2 asthma. So we call this test as FeNO. Third thing is the eosinophil count. FeNO will be increased. Eosinophil count will be increased. That is why whenever some doctor diagnoses asthma, first thing he will do is check the eosinophil count, absolute eosinophil count, right? Elevated means you're dealing with type 2 asthma. And then we have a new molecule called as osteoprotegerine. Osteoprotegerine. So these are all markers of type 2 asthma. If these are positive, you have a case of type 2 asthma. If these are negative, you have a case of non-type 2 asthma. Okay. Now, if I have a patient with asthma, how will they present? They will present with cough and wheeze, which is going to be usually episodic because obstruction is not permanent. So whenever obstruction happens, they will cough and wheeze and feel short of breath. When obstruction relieves, they will be fine. So when such a patient presents, right, how will I make the diagnosis? The diagnosis of asthma, please remember, it is not based on auscultation of wheeze. It is based on PFT, right? The investigation of choice for diagnosis of asthma is not X-ray, not clinical examination. It is PFT. So what do we do in PFT? Yes, as we know, we will look at the FEV1 by FVC ratio. It will be less than 0.7. That indicates that we have obstruction. That does not prove that we have asthma. So after that, we have to go for the bronchodilator reversibility test. So we'll administer short-acting beta agonist. And then after that, FEV1 generally increases by more than 12% or more than or equal to 200 ml. So a single jump of 200 ml or 12% from the baseline value. That improvement means you have reversible obstruction. So this indicates that you have got reversible obstruction and that means you have asthma. Okay, should I do the chest X-ray for diagnosis? Absolutely no. But if you're suspecting that an infection is triggering or worsening the asthma, you can do the chest X-ray to see there is a consolidation or not, but not for the diagnosis. Now, one more question on diagnosis that they will ask you is, what if this spirometry is not possible? What is the alternative we can have, right? PFT or spirometry is the investigation of choice. Alternative to PFT for diagnosis. Alternative to PFT for diagnosis will be peak expiratory flow rate. PFT requires a full-fledged setup. Instead, you don't have. There is a small handheld device where you ask the patient to blow the air, which will calculate the rate, peak rate, or the maximum rate of the flow of air. That is what we call as peak expiratory flow rate. Okay. So in asthma patients, this will obviously be decreased because we are obstructing expiration more than inspiration. So expiratory flow rate will be decreased. But that also does not prove that it is asthma. It only proves that obstruction is there. So I have to prove that this is asthma. So how do I do that? Again, we do the BDR test. Only thing I want you to remember here is that as an examiner, if I am setting the question paper, I can tend to confuse you by giving two values. The BDR test done for interpretation of improvement in FEV1 is different, and the BDR test done for improvement in PFR will be different. So I have done the baseline PFR, right? And I give a short acting beta agonist. I will recheck the PFR. So if the PFR increases by more than or equal to 20%, 12% for FEV1, PFR 20%. That means we have reversible obstruction. That indicates that we have a case of asthma. Simple, right? So investigation of choice is PFT. नहीं होता है तो PFR. PFR is a simple and convenient alternative. Once we have diagnosed the asthma, right? How do we manage a patient with asthma? For a patient with asthma, there are several problems. The most important problem is that they go through repeated attacks of asthma. Whenever they're going to attack of asthma, they have wheeze, shortness of breath, and cough. That needs to be relieved. So for relieving, what is the best drug? A short-acting beta agonist. So to relieve an attack, the best drug, we call it as reliever. It is going to be a short-acting beta agonist. But if I have to prevent an asthma from coming, an attack from happening, because relief se pehle kuch minutes ka suffering is there. Best thing would be to prevent. So how can I prevent? We need two medications. One, a long-acting beta agonist so that the bronchial tree remains dilated. And what is the underlying mechanism? Attack by eosinophils or neutrophils. So if I can reduce the eosinophilic or neutrophilic inflammation, then asthma attacks will come down. How can I reduce? By giving steroids. So for maintaining asthma, we call them as maintenance medication. For maintenance, we use a combination of, we would require long-acting beta agonist and we would require inhaled corticosteroids. Now, when it comes to combining these, right, it is really confusing for the patient because patient need to have three inhalers. He should take one long-acting beta agonist and one inhaled corticosteroid for morning and evening on a regular basis if it is significant asthma. And whenever an attack happens, despite taking these, he should take a short-acting beta agonist. It can turn very confusing for the patients because they will flip these inhalers, right? I have had experience of patients taking only inhaled corticosteroids whenever there is an asthma attack, and on a daily basis taking SABA plus LABA. So none of the objectives are achieved in such cases, right? So what we do now is we have a drug which is a long-acting beta agonist, but very rapid onset in action. Which drug I'm talking about? Rapid onset LABA. That is formoterol. So since the advent of formoterol, our treatment has become very simple. When the eosinophil count test to be taken before the treatment, see, once we start someone on the steroids, especially the inhaled corticosteroids or the oral steroids, we will tamper with the pathophysiological mechanisms and eosinophil count can drop down. So after that, interpretation becomes very difficult. That is why I would personally advocate that the day you make the diagnosis of asthma, before you give them any prescription, until and unless it is the status asthmaticus or severe asthma, please draw the investigations for the biomarkers and then start your treatment, because the treatment might tamper the biomarkers. So type 2 might turn out like negative, markers might turn negative despite having type 2, and you may label it as not. So since the advent of formoterol, the preferred inhaler, right, preferred combination that we now follow is a combination of formoterol plus inhaled corticosteroid. Now the advantage is the patient can take the same inhaler morning and evening. So he is getting the benefit of LABA because formoterol is long acting, plus he is getting the inhaled corticosteroid. So that is maintaining and reducing the attack frequency. And whenever an attack happens, all he has to do is take the same inhaler one more puff, because formoterol is rapid onset, just like any other LABA. So it will relieve the attack, prevent the attack. So since then there is no confusion. Patient needs to carry one inhaler. Now, depending on the severity, we choose low dose to start with or medium dose, depending on the severity. Okay, and we follow a step ladder approach. So if I started with low dose, not controlled, I go to medium dose, not controlled, I go to the high dose. Okay, but generally we do not prefer using high dose combinations, because high dose means we are talking about high dose steroid. And when we give high dose steroid, there is increased risk of oral candidiasis. So what we do is, once we are saturated with medium dose combination of formoterol and ICS, still asthma is not controlled, then we start thinking of alternatives. So asthma not controlled with not controlled with medium dose. I forgot to mention this combination treatment, right? If we are giving it as a maintenance medication and not as and when required, we call it as maintenance and reliever treatment. Means the same medication we're using for maintenance, same medication we're using for relief. So we call it as maintenance and reliever treatment, or MART. So when the asthma is not controlled with medium dose MART, when it is not controlled with medium dose MART, right? What are the treatment options we have? What are the treatment options we have? So one option is you can go to high dose MART, which is not preferred by most of the doctors for a simple fact that high dose MART will lead to oral candidiasis. But that is one option, as I mentioned. So options include, one option is high dose MART, that is combination of formoterol and steroid, high dose steroid, right? Not preferred because of risk of oral candidiasis. Risk of oral thrush. Okay. Then what other option we have? I can think of continuing with the medium dose MART, but we can add long-acting anti-muscarinic agents. Remember, bronchoconstriction, to relieve it, we can either give beta agonist or blocking the parasympathetic nervous system. So we can also consider LAMA. Or third option we can use is biologicals. That is monoclonal antibodies. What biologicals options we have? One option we have is called as dupilumab. Dupilumab. The second one is reslizumab. Third one is benralizumab. Benralizumab. And the fourth option is mepolizumab. And one more very famous option, which is the first monoclonal antibody available for treatment of asthma, and that is called as omalizumab. Omalizumab. Now, monoclonal antibodies and their mechanism of action had always been an MCQ topic. Almost every exam will have one question asking what is the mechanism of action of this particular monoclonal antibody, or where do we use it. So you need to make a table and kind of memorize it. So we will definitely do that for at least these drugs. Dupilumab is a monoclonal antibody against anti-interleukin 4 receptor monoclonal antibody. Okay. Reslizumab and mepolizumab, right? These two are monoclonal antibodies against anti-interleukin 5 monoclonal antibody. Benralizumab is an anti-interleukin 5 receptor monoclonal antibody, and omalizumab is anti-immunoglobulin E, IgE monoclonal antibody. So now look at these antibodies and tell me which type of asthma these drugs are useful. Is it type 2 or non-type? In which asthma interleukin 4, interleukin 5 and eosinophils are involved? IgE is involved. It is type 2, right? All the list of drugs that I made are useful for a patient with type 2 asthma, right? Then what about the patients with non-type 2 asthma? So till recent times, like till last couple of years, we did not have much important monoclonal antibodies for treatment of non-type 2 asthma. So we have to hit them with steroids with all its side effects and consequences. And that is why we used to say that non-type 2 asthma is a nightmare for a treating doctor. But in the recent times, we have some better drugs available and we know how to manage it. So all these drugs that we mentioned here are for type 2 asthma. They are for type 2 asthma. Now the question is, how do I remember all these, right? So there are some easy hacks to remember it. When you look at dupilumab, D is the fourth letter of alphabet. So that way you can easily remember it, that it is against interleukin 4. D is the fourth letter of alphabet, right? Then omalizumab, I want you to remember because it is the oldest monoclonal antibody for asthma. Means when I was doing MBBS back in 2001, this was already, I think, already there. Like in my second year or third year pharmacology, I started studying about it. So it's a very, very old drug. So I want you to remember it. Okay. Then all the remaining drugs that we have mentioned here are the monoclonal antibodies against interleukin 5. Only confusion that can emerge if they ask a very tricky question is which of them are targeting the interleukin 5 directly and which of them are blocking its receptor. The one that is blocking its receptor is benralizumab. Easy to remember. What you have to remember when reading is, instead of reading it as benralizumab, read it as ban-aralizumab. Read it as ban-aralizumab. So that way you can remember that it is against IL-5 and it is banning the receptor. Banning the receptor. So then remaining racemozumab, mepolizumab are directly acting on the interleukin 5. Okay. Now, what is the new drug that is now useful for patients with non-type 2 asthma? The drug is called as tezepelumab. What is it? For all these helper T cells, for their proliferation, they require some cytokine, which is called as thymic stromal lymphopoietin or TSLP. There is a substance called as TSLP. So against that, this monoclonal antibody acts. So tezepelumab is an anti TSLP, thymic stromal lymphopoietin. What is this TSLP? TSLP is a cytokine required for proliferation of all these helper cells. So whether it is Th2 cell, Th1 cell, Th17 cell, we need TSLP. So if I block TSLP, I can reduce the activity of Th2, Th1, Th17. So the result is I can use it for type 2 as well as the non-type 2 asthma, right? So that is the only monoclonal antibody right now approved by the FDA for treatment of type 2 as well as non-type 2 asthma. This is for both type 2 and non-type 2 asthma, right? So let's get back to the question and quickly jot down the answer. The question is very straightforward. Right? Which of the following biological can be used for both type 2 and non-type 2 asthma? The answer is tezepelumab. Tezepelumab, right? Omalizumab is anti-IgE that can only be used for type 2 asthma. Benralizumab, I told you to remember ban-R-alizumab, banning the receptor. So it is an anti-interleukin 5 receptor monoclonal antibody that is also useful only for type 2 asthma. Okay. What is this natalizumab? Can anybody tell me where do we use this natalizumab? Okay. So natalizumab is a anti alpha 4 integrin monoclonal antibody, which is currently primarily, it is nothing to do with asthma. It is used for patients with multiple sclerosis. For patients with multiple sclerosis. Is used for patients with multiple sclerosis. Okay. The last point. How do I remember that tezepelumab is against anti-TS is against TSLP? Easy, right? T for T. Tezepelumab for TSLP. Okay. Clear. So one more question here. A 65-year-old man presented with 6-month history of progressive difficulty in swallowing and chewing. He complains of drooping of both eyelids that worsen throughout the day. On examination, you notice fatigable weakness of the bulbar muscle and ptosis. Which of the following would be the most specific test for the diagnosis? A very similar, very similar question also appeared in the recently concluded FMG exam. So first thing you should tell me is what is the diagnosis? What makes you think that as the diagnosis? And then we will talk about its management. So the important clues here are that patient has got drooping of both the eyelids, right? He has difficulty in swallowing and chewing. And the symptoms are worsening throughout the day. So as the day progresses, the symptoms are getting worsened. And another clue here is there is a fatigable weakness, means the more you try to use the muscle will go on becoming more and more weak. So what does that point towards? Right. So this is a very simple and a straightforward question of myasthenia gravis. Myasthenia gravis. Okay, so few questions about myasthenia gravis. The first question is, it is a neuromuscular junction disorder, right? Now, neuromuscular junction disorders are categorized into two groups, the presynaptic disorders and the postsynaptic disorder. So is it a presynaptic disorder or postsynaptic disorder? So what do I mean by that? See, this is a presynaptic nerve terminal. This is a presynaptic nerve terminal. And on the other side, you have the muscle side, right? And this is the synaptic cleft. So if the pathology affects the conduction of the presynaptic neuron, then it is called as presynaptic neuromuscular junction disorder. If the pathology is not affecting the presynaptic neuron, it is affecting the postsynaptic muscle membrane, then we will call it as postsynaptic neuromuscular junction disorder. So please remember, what is causing myasthenia gravis? Antibodies which are blocking the acetylcholine receptors. Which type of acetylcholine receptors? The nicotinic type of acetylcholine receptors. Antibodies are blocking these acetylcholine receptors. So where is it happening? Postsynaptic membrane. So myasthenia gravis is a postsynaptic neuromuscular junction disorder. A classical example for a presynaptic neuromuscular junction disorder is going to be Lambert-Eaton myasthenic syndrome. So first thing is myasthenia gravis. It is a postsynaptic neuromuscular junction disorder, NMJ disorder. Okay. Can I say this is an autoimmune disorder? Yes, it is an autoimmune disorder because there are antibodies being formed. It's an autoimmune disorder. Normally, autoimmune disorders are common in which gender and which age group? Generally, autoimmune disorders are common in females. So it typically affects females more than males, and majority of the cases of autoimmune disorders in females happen in their reproductive age group or the middle age, right? Young to middle age. But when it comes to myasthenia gravis, it does affect males also, but obviously elderly males. And one question that they will ask you is between a young female with myasthenia gravis and an elderly male with myasthenia gravis, who carries the worst prognosis? And the common answer that most students write is it is the young female who carries the worst prognosis. And I've got justification from the students saying that, sir, when it comes to myasthenia gravis, who should we think of? One famous celebrity, that is Amitabh Bachchan. In India, myasthenia gravis discussion does not complete without talking about Amitabh Bachchan. So Amitabh Bachchan is doing hell and hardy and doing well, no issues with him. So that means the prognosis is good. Please do not relate to one single case, right? Amitabh Bachchan has all the possible facilities in the world, so he can take care of his health and he'll have a longevity. Obviously, longevity also depends on your financial capabilities. Generally, remember, any disease which typically affects females, right? If it affects males, it carries worse prognosis. Just to give you an example, right? Breast cancer is the disease of females. Rarely ever it happens in males, but if it happens in males, it will be very aggressive and carries poor prognosis. Same applies to myasthenia gravis. So myasthenia gravis can affect, like, the age wise, there is a bimodal presentation. Bimodal presentation. So you will see one peak in the age range of 30 to 50 years, and you will see another small peak in the age range of 60 to 80 years age group. Most of the females in who develop myasthenia gravis, they will be in this 30 to 50 age range, and most of the males who develop myasthenia gravis, they will be generally elderly. And this young female developing the myasthenia gravis carries better prognosis than an elderly male developing the myasthenia gravis. Okay. Now, this being an autoimmune disorders, obviously there are antibodies involved. So the question is, what antibodies I should think of? Antibodies involved. The most commonly seen antibody, right? The most common antibody is going to be anti-acetylcholine receptor antibody, anti-ICHR antibody. That is the most common antibody. And if positive, right? Such case of myasthenia gravis, we call it as seropositive myasthenia gravis. If negative, we can blandly label it as seronegative myasthenia gravis. In such patients where we don't get anti-acetylcholine receptor antibody, which other antibody I should look for? There is another antibody which is second most common antibody. That antibody is called as anti-muscle specific kinase antibody or anti-musk antibody. Okay. Sometimes this also will turn negative. So if this is positive, if positive, we will count it as seronegative myasthenia gravis. अगर ये भी negative है तो then only we go for the next antibody, which is third most common, or you can rather label it as relatively the least common among the three antibodies that we see in a patient with myasthenia gravis. And that antibody is called as anti-lipoprotein 4 receptor antibody or anti-LP4R antibody. Right? If ये positive आता है, see, please remember, when we check for the antibodies, right, we don't do all the antibodies in one go. We first check the most common. Positive है तो seropositive. Negative है तो we go for the next. वो positive निकल आता है तो then we will call it as seronegative. That is also negative, then we go for the third antibody. And if that turns out to be positive, then we call it as double negative myasthenia gravis. Why are we calling it as double negative myasthenia gravis? Because in this case, the first two antibodies, the commonest antibodies, the anti-acetylcholine receptor and anti-musk, दोनों negative है, so we call it as double negative myasthenia gravis. Okay. Now, what clinical features these patients are going to present with? These patients will present with the earliest symptom will be ptosis. Why ptosis? Because levator palpebrae superioris is the earliest affected muscle. So that is again an important MCQ. Earliest affected muscle is going to be levator palpebrae superioris. Why that is the earliest affected muscle? Because the acetylcholine use for this muscle is maximum because we're constantly blinking. So we'll use up most of the acetylcholine, right? So in fact, one of the questions that they will ask you is the sequence of involvement of muscles. Sequence of muscle involvement, right? So what do we see here? The first affected is levator palpebrae superioris. Levator palpebrae superioris. Can anybody tell me what is the next most commonly used muscle in our body after levator palpebrae superioris? So now when you're listening to my lesson, right, you're constantly scanning through the screen, whether you're sitting in front of an iPad or a monitor or a phone, your eyeballs are moving. So your extraocular muscles of extraocular movement, they are most commonly used. So they will lose up the acetylcholine early. So they will be the second most affected in the hierarchy, right? So muscles of extraocular movement. Extraocular movement. So when levator palpebrae superioris got affected, what symptom I should expect? Levator palpebrae superioris involvement will lead to ptosis. Once the muscles of extraocular movement get affected, the extraocular movement, eyeball movement is impaired. Now I will not be able to maintain a good axis. So I will develop diplopia. So this will result in diplopia apart from eye fatigue. Okay. After this, the next usual affected muscles are the proximal muscles. What are proximal muscles? Proximal muscles are muscles of your shoulder joint and hip joint. So now patients will have weakness of these muscles because these are routinely used in day-to-day activities. When you're walking, you're moving, there is a swing of the arm, you're walking, so you're using your hip joint muscles. So they will lose their, what to say, acetylcholine. So they will become weak. So that will lead to difficulty in lifting objects, combing, climbing, right? All those problems. After that, in the sequence, see when they get affected, we will call it as proximal muscle weakness. Proximal muscle weakness. From here, now there will be involvement of muscles of facial expression. Why they are getting affected? Because when we are talking, when we are right awake, we are giving expressions on the face. So how do we bring those expressions? By contracting the muscles of facial expression. So we will have facial muscles affected next. And the involvement of facial muscles will lead to what? It will lead to drooping of face. Drooping of face that is being described in this question. In fact, drooping of face gives rise to a peculiar finding in patients with myasthenia gravis, which indeed can be an image-based question. That is, when you ask a patient with myasthenia gravis to smile, the face is drooped, they will not be able to lift the facial muscles so well, so they will not give you an electric smile. The smile will be very weird. It looks like a dog is trying to scare them, like dogs, they do this scaring by showing their teeth. So their face also looks like that, and that is called as snarling faces. We call it as snarling faces. So they can ask you, where do you see snarling faces? Or they can ask you to use different kinds of facial appearance and the conditions and match. That is a possible MC called as snarling faces. What are they doing? They're trying to, like, their teeth is visible because only part of the facial muscles are able to lift the lip, not a complete electrical smile is not possible. So we call it as snarling faces. The least or the last affected muscles are going to be the small muscles of your hand and feet. We call them as distal muscles. So patients with myasthenia gravis generally do not have grip weakness. They don't drop objects. They can't lift objects. They can hold, they can't lift because proximal muscles are weak. These are the sequence of involvement of muscles and the flow of symptoms, right? Then the hallmark of the patient's symptoms is characteristically there is diurnal variation. Hallmark of neuromuscular junction disorders, that is diurnal variation. Because whatever acetylcholine we have synthesized throughout the night, we start using up as we start using the muscles. So acetylcholine decreases as the day progresses. So severity of weakness increases, right? So In myasthenia gravis, weakness worsens as day progresses, because in myasthenia gravis, the more we use the muscle, more weak it becomes, right? So you have to make another note here. A close differential diagnosis is Lambert-Eaton myasthenic syndrome, right? So in Lambert-Eaton myasthenic syndrome, there is diurnal variation. Diurnal variation is the hallmark of neuromuscular junction disorder. Diurnal variation is the hallmark of neuromuscular junction disorders. Lambert-Eaton is a presynaptic neuromuscular junction disorder. So in LEMS, the weakness improves as the day progresses. As the day progresses. So basically, both of them have variation in their weakness as the day progresses. But myasthenia gravis, they start their day very well, right? Normal, almost all muscles fine because sufficient acetylcholine is there. I start using the muscles, I start using up the acetylcholine goes on depleting, muscles will become weak. First levator, palpebrae superioris, extraocular muscles, proximal muscles, face muscles, distal muscles, it goes on becoming weak. In Lambert-Eaton myasthenic syndrome, they start their day very weak. Right? They might have even difficulty to get up from the bed. They might require assistance. But as they start using the muscle start gaining the strength. And by evening, they are perfectly fine. Morning is terribly weak, evening perfectly fine. So in this question, we have all those parameters. So that is why we have made the diagnosis of myasthenia gravis, the clinical diagnosis. Now, a clinical diagnosis, how would I confirm? We should also be aware about the examination points, right? On examination, basically we will look for the power of the muscles. Obviously, affected group of muscles, the power will be decreased. We will look at the tone and deep tendon reflexes, right? So what you have to remember is in myasthenia gravis, it is a disorder of neuromuscular junction, where tone decreases in disorders of the peripheral nerves or lower motor neuron damage, where tone increases in disorders of the upper motor neuron. Neuromuscular junction is not a motor neuron. So when myasthenia gravis happens, tone is not affected. Deep tendon reflex are not affected. So they will mostly be normal. Okay. Now when it comes to the confirmed diagnosis, I have to rely on the lab. So what tests we do? There are a few MCQs they will ask. In a recently concluded FMG, there were plenty of MCQs on myasthenia gravis. So first thing they will ask you is what is the most sensitive test? Most sensitive test. The most sensitive test is single fiber electromyography. Single fiber electromyography. Then they will ask you what is the most specific test. Most specific test is finding the antibody against acetylcholine receptor. Anti-acetylcholine receptor antibody. Okay. Then they will ask you what is the most commonly performed test. Most commonly performed test. And this is where many students give a wrong answer. That is the hydrophonium test or tensilon test. We do not perform it routinely. The most commonly performed test is repetitive nerve stimulation test. Repetitive nerve stimulation test. In the recent FMG, they had asked about the interpretation of repetitive nerve stimulation test. I will give you the points that you need to remember for answering those questions. Okay. Then what other test we are left with? They will ask you the screening test. What is the screening test used for detection of myasthenia gravis? Screening test is obviously a highly sensitive, easy to do kind of test, right? So that is ice pack test. So what do we do in ice pack test? If there is an eye with ptosis, we apply an ice pack. Obviously, patient will close the eye, we apply an ice pack, and we will remove it later, and we will see what happens to ptosis. If it is myasthenia gravis, what should happen to the ptosis? Should it improve, persist, or worsen? So when we applied the ice pack, first of all, we have stopped the blinking. So when we stop the blinking, we are not using the acetylcholine anymore. We are giving sufficient time for the acetylcholine synthesis. So when we remove the ice pack, now we have more acetylcholine in the levator palpebrae muscle. So it will be able to contract and we will not develop the ptosis. The ptosis will disappear. So in myasthenia gravis, on ice pack test, the ptosis disappears. Ptosis disappears. Okay, clear? Now, the last test you should know is the tensilon test or the hydrophonium test. This is not routinely performed because it is cumbersome and not a very safe test because it can cause cholinergic crisis. So not routinely performed, but you should know how to do the basic interpretation. So in a patient with myasthenia gravis, if I give edrophonium, right, it is an acetylcholine esterase inhibitor. So by blocking the acetylcholine degradation, I will have more acetylcholine in the neuromuscular junction. So what will happen to the symptoms or the ptosis? Improves, right? So an administration of tensilon or edrophonium, right, improvement in ptosis, or if other symptoms are present, improvement in other symptoms on administration of edrophonium. That is what we would encounter in a patient with myasthenia gravis. Now for the exam, what is important? Most importantly, nowadays they are asking related to RNST and its interpretation. So how do we interpret RNST, repetitive nerve stimulation? So please remember, myasthenia gravis, the more I use the muscle, the more muscle weak it becomes, right? Here. So we give repetitive electrical stimulation to the muscle and we will see the force of contraction, right? How do we assess the force of contraction? By looking at the muscle action potential. And because I'm not measuring the muscle action potential from single muscle fiber, but the whole muscle, we will call it as compound muscle action potential. So in RNST, we will apply repetitive stimulation, and we will assess the repetitive stimulation of the muscle and we will assess the compound muscle action potential. Okay. So if compound muscle action potential goes on decreasing, that means the force of contraction of the muscle is decreasing. The more and more I stimulate, the force of contraction of the muscle is decreasing. So if compound muscle action potential goes on decreasing, we call it as decremental response. Decremental response. So where do we see the decremental response? In patients with myasthenia gravis, and if the compound muscle action potential goes on increasing, right, after the more and more I give the electrical stimulus, muscle contracts with more and more force. So then we call it as incremental response. Increasing response will be called as incremental response. Incremental response. So where do I see this incremental response? One is Lambert-Eaton myasthenic syndrome, and one more toxin can also cause, which is also a neuromuscular junction affecting the neuromuscular junction. So incremental response can be seen in Lambert-Eaton myasthenic syndrome, and it can be seen in botulinum toxicity. Botulinum toxicity, or botulism as you call it as. So this is what the recent FMG was asking about. Where do you get a incremental response? So we get incremental response in Lambert-Eaton and botulinum toxicity, decremental response in patients with myasthenia gravis. Okay, so now let's get back to the question. I think hopefully we should be able to answer it now. A 65-year-old man presents with 6 months history of progressive difficulty in swallowing and chewing. He has complaints of drooping of both the eyelids and worsening of the symptoms throughout the day, ptosis, fatigable weakness of bulbar muscles and ptosis. Clinically, myasthenia gravis, what would be the most specific? So what are they asking here? What would be the most specific test? What is most sensitive test? Most sensitive is single fiber electromyography. So SF-EMG is similar to the repetitive nerve stimulation. Only difference is that here we are selecting only one muscle fiber and stimulating it and seeing whether the contraction force increases or decreases. In repetitive nerve stimulation, we are stimulating the whole muscle. Isolating a single fiber is very difficult. So it is sensitive but not practical, right? So this is the most sensitive test. Anti-acetylcholine receptor antibody assay, that will be the most specific test, right? Nerve conduction study has no role. We use nerve conduction study for the diagnosis of neuropathic disorders like GB syndrome or diabetic neuropathy. Okay. So that is about this question. Now, last bit point about the management, right? So when it comes to management of a patient with myasthenia gravis, what question they will ask you? First question they will ask you is, what is the drug of choice for management of myasthenia gravis? So when it comes to myasthenia gravis, right, we have to see whether patient is in crisis situation or stable. So MG myasthenia gravis patient, if he is in what is called as myasthenic crisis, how do you manage? And if it is a patient with chronic stable myasthenia gravis. Now, what do I mean by crisis situation? It is a situation where patient has developed weakness of respiratory muscles, resulting in respiratory failure. So when myasthenia gravis has resulted in respiratory failure to the point that you need to put them on ventilator, right? Myasthenia gravis resulting in respiratory failure requiring ventilator. Then we call it as myasthenic crisis. Myasthenic crisis. So how do we treat these patients? The treatment primarily focuses on first put them on ventilator. Otherwise, even before your drugs start working, the patient will be dead because of hypoxia, right? Second thing is, now I have to quickly reduce the antibody load in the body and quickly increase the acetylcholine levels. Reduce the antibodies quickly, increase the acetylcholine quickly. How can I increase the acetylcholine quickly? I need to give the more stronger and rapid onset acting the acetylcholine esterase inhibitors. So we can use drugs like neostigmine or physostigmine. We can use drugs like neostigmine or physostigmine. We do not use pyridostigmine because pyridostigmine is low onset, long acting. These are short acting but rapid onset and potent. So we can use neostigmine or physostigmine. Plus, how can I reduce the antibodies which are already there in the circulation? By inhibiting the B lymphocytes or giving immunosuppressants or steroids, I will not be able to reduce the antibodies which are already produced. How can I remove them? Right, I can remove them by giving immunoglobulins, IVIG, which can neutralize the antibodies, or we can do plasma exchange or plasma pheresis. So this is how we treat a patient in myasthenic crisis, where myasthenia gravis has affected respiratory muscle, patient has developed respiratory paralysis, put him on ventilator, give neostigmine or physostigmine so that the acetylcholine level starts rising up, and to reduce the antibody loads, either give immunoglobulins or patient's plasma is exchanged with a healthy person on multiple sessions that antibodies are now washed up. That is how we deal. Now, for a chronic stable myasthenia gravis patient, it is like evening, I'm feeling very tired, I have Torsades, I have diplopia. Otherwise, I don't have a respiratory problem. That's a chronic stable myasthenia gravis patient, right? So in them, how do we treat? The drug of choice for the symptomatic improvement. How do I achieve the symptomatic improvement? By increasing the acetylcholine. How can I achieve that? By blocking the acetylcholine esterase. How can I block the acetylcholine esterase? Here, because I need to take it on a daily basis, regular basis, I need a long-acting agent. So the drug of choice becomes pyridostigmine, right? Pyridostigmine will be the drug of choice for myasthenia gravis, important MCQ. But that is not alone sufficient. We also treat these patients because this is only increasing the acetylcholine. But as long as antibodies are there, they will still come and bind the receptors and your acetylcholine may not be able to bind it. So I have to reduce the antibodies. How can I reduce the antibodies? By giving steroids. We can consider steroids because steroids will inhibit B lymphocytes. B lymphocytes are the one which are producing antibodies. But if I use too much steroids, obviously side effects of Cushing syndrome, all that. So I have to minimize the use of steroid. How can I do that? By taking help of immunosuppressants. So we use immunosuppressants like azathioprine. Immunosuppressants like azathioprine. I'm just giving you an example. There are various other immunosuppressants that we can use. Okay. Now, apart from these, for selected patients, we consider doing a gland removal. Which one? We can consider doing thymectomy. In which patients it is useful? It is useful in only for seropositive myasthenia gravis patients. It is not useful in seronegative myasthenia gravis. Means if you have anti-MuSK or anti-LP4 antibody, this is useless. You should use it only when you have anti-acetylcholine receptor antibody positive. That is when we call it as seropositive. Right? For seropositive myasthenia gravis with age of the patient less than 55 years. Very, very important point. Why? Because after 55 years of age, the risks of surgery outweigh the benefits that we can derive from removal of the thymus gland. because thymus gland is a mediastinal organ. We need to have more complex surgeries. We avoid it if it is 55 plus. So you have typical case which undergoes thymectomy is mostly going to be young females, because if they are getting myasthenia gravis before 55, it is mostly females. If males develop myasthenia gravis, majority of them are going to develop in their 60s, 70s. They were by default unfit for thymectomy. So it is like mostly young females developing myasthenia gravis with anti-acetylcholine receptor antibody are the candidates for thymectomy. Okay. So before I wind up, right, one last question I have. What if I start treating the patient with heavy doses of pyridostigmine because I want more improvement in the strength? Then what will happen? See, primarily acetylcholine, once formed, right, it gets degraded to choline and acetic acid by the enzyme acetylcholine esterase. So if I block acetylcholine esterase, acetylcholine level will increase. But what if it gets too much increased? What complication I can expect? Or can you give me an example of a situation or a disorder where there is very high amount of acetylcholine? Okay. In India, I think all of us are familiar with organophosphate compound poisoning, right? OP poisoning. Many of our farmers, when they commit suicide, their go-to choice is organophosphate compounds, right? So what are they? They are basically acetylcholine esterase inhibitors. So what do? Increase the acetylcholine levels. So when acetylcholine level increases, right? They come to the hospital with many symptoms, but many of them do die, right? Why do they die? What is the reason for death when you have very high acetylcholine in your neuromuscular junction? See, remember this acetylcholine will start stimulating your muscle. What is the job of acetylcholine? Stimulate the muscle to contract. So your muscles will go into hypercontractile state. They will contract vigorously. But when they vigorously contract, we just learned when we were talking about Takotsubo cardiomyopathy. And I sent adrenaline to stimulate the cardiac muscle. What happened? Muscles lost all their ATP because they were responding to the stimulus. Similarly, when acetylcholine increases too much, your muscles are hyperstimulated. They start twitching. If you see OP patients, right, they will have all these fasciculations or twitching because their muscles are being stimulated. When they're stimulated, they're using up all the glycogen, glucose, and ATPs. Once they reach a threshold where ATPs are severely depleted, the muscles stop working. Right? So when they stop working, especially the respiratory muscles stop working, we will develop respiratory paralysis and we can die out of it. And that is why if you go to wards, you might have seen that your residents or PGs or professors often ask the patient to lift the neck up and hold. They're assessing whether patient has the muscle strength. If they are not able to hold the neck when lying down, lift up from the bed and hold, that means their respiratory muscles are also getting affected and these patients are likely to die. So such patients, we prophylactically put them on ventilator so that if their respiratory muscles can't do the function, at least let the machine do till they recover. So if I give too much of pyridostigmine, I can end up in a similar situation. So my muscles will become weak, respiratory muscles. So when that happens, right, the story is I have a myasthenia gravis patient who is not able to breathe. So I can easily get confused with the situation as myasthenic crisis. What is myasthenic gravis? Crisis, severe deficiency of acetylcholine. Now, what is happening if I am giving too much pyridostigmine? Too excess acetylcholine, but both of them are presenting with respiratory failure. So this we call it as myasthenic crisis, and too much of acetylcholine resulting in respiratory failure, we will call it as cholinergic crisis. So one of the MCQ that they are going to ask you is how to differentiate between the cholinergic and the myasthenic crisis. So that will be one more topic that we will quickly discuss today before we wind up and we will connect with another session. The difference between the cholinergic crisis and myasthenic crisis. Right. So both of them, the clinical presentation of both of them is respiratory failure. Right. Presentation of both of them is going to be respiratory failure. So if it is in the backdrop of a patient with myasthenia gravis, I will not be able to quickly decide whether it is myasthenic crisis or the cholinergic crisis. And if I misdiagnose, I can harm the patient. Right? For example, if I think that a cholinergic patient is having myasthenic crisis and I give him more pyridostigmine, or if I give them neostigmine or physostigmine, I will worsen the situation. Right? So I should know this. So how do I get to know? What is the underlying pathology? The pathology in cholinergic crisis is because of over treatment with medication, there is increase in acetylcholine. This extra acetylcholine is stimulating the muscle to the point that they are losing all their energy or ATP. In myasthenic crisis, there is no sufficient acetylcholine available to stimulate the muscle to contract. right? Ultimately, both cases, muscles are not able to do their job. Now, what parameters will help me to understand whether a particular individual has high acetylcholine activity or not? What parameters? So when you see a patient with OP poisoning, right? What all examination findings you will look for? Most importantly, you will look at the pupils, right? Pupils hold a very important clue. So what will happen to pupils in cholinergic crisis and what will happen to pupils in the myasthenic crisis? Atropine is the antidote for OP poisoning. So whatever happens on administration of atropine, opposite of that should happen in OP poisoning. Same should happen in patient with cholinergic crisis, right? So pupils will become constricted or they will develop meiosis, right? Pupils will not be much affected in patients with myasthenic crisis. So meiosis holds one important clue, right? Apart from that, when there is excess acetylcholine, it leads to stimulation of glands to produce more secretion. We call the symptoms as sludge symptoms, as a mnemonic, right? Salivation, lacrimation, urination, defecation, right? Gastric symptoms, and gastric symptoms is the pain abdomen, and emesis or vomiting. So from, in simple words, when acetylcholine increases, patients start throwing out fluids from all their orifices, right? Everywhere he is leaking fluids. So we call it as sludge symptoms. So they are typically present in a patient with excess acetylcholine. If you see any patient with OP poisoning, they will have the same symptoms: drooling, saliva, salivation, lacrimation, urination. Everywhere there is fluid. On the other hand, the sludge symptoms will be absent in a patient with the myasthenic crisis. Now, if on these two parameters, basis of these two parameters, if I'm not able to conclusively decide whether it is myasthenic crisis or cholinergic crisis, the only next option I have is to do the tensilon test. So in tensilon test, we administer a acetylcholine esterase inhibitor. So by administering acetylcholine esterase inhibitor, we increase the acetylcholine levels. So if I increase acetylcholine levels in a patient with cholinergic crisis, what will happen to the symptoms? They will worsen, right? It will lead to worsening of secretions, everything, because I'm increasing more acetylcholine. But in case of myasthenic crisis, the increase in acetylcholine will offset or improve the symptoms. So there will be improvement in the patient symptoms. So that will be the last ditch effort to differentiate between the cholinergic and the myasthenic crisis. So that is about our myasthenia gravis. I think we have addressed all the points that could potentially come as the MCQ. Okay, so the time is up. I will take a break now, and then we will have one more session hopefully, and we will continue with few more topics from the neurology, that is about the acute management of stroke. That is an important topic. And then we will have few more topics from rheumatology as well as the nephrology in the subsequent session. So for now, this much. The notes will be available to you on the Telegram soon and also as well on the app. Wishing you all the best, guys. Study well. Focus on the high yield topics. So important high yield topics from respiratory, cardio, and some topics from neuro are covered in one more session. Remaining neuro topics, some rheumat and some nephro topics also will be. Okay. So that's it from me, guys. Tomorrow there will be another subject session. Somewhere in between, when there is a window period, I will sneak in and put one more session for medicine. See you guys. Bye.